Hello, everyone. Warm welcome to everybody on a Saturday afternoon. And let me first thank you all, audience, for being here on a afternoon, on a weekend. And I hope you will be enjoying the academic feast. So I welcome on behalf of four societies, Sphere, Center for Behavioral Medicine, the Indian Psychiatry Society West Zone, and Mahatma Gandhi Trust, Aurangabad. So this is a fourth international conference on mind-body medicine in diabetes and endocrinology, the Synapse 2023. And to start with the sessions, I would like to introduce our moderator for the first session, Dr. Madhura Samudra. Hello, Madhura. And can I have a CV slide, please? Yes. So Dr. Madhura Samudra is a young budding psychiatrist, and she's just finished with her psychiatry studies and now into practice. She has been a speaker at the World Psychiatric Association conference in 2020. She has published in the WHO COVID-19 database. She's actively working in raising awareness in mental illness on various platforms. She's a certified child and adolescent sex educator, and I would like to say that she's been very actively involved with all our mind-body medicine activities, very enthusiastic. And over to you, Madhura, for the proceedings.
Thank you, ma'am. Good afternoon to all the delegates who have joined. I would like to welcome you all for the Synapse 2023 conference. I would also like to introduce the next speaker who will present the presidential address for today. Could I see the slide, please? So our next speaker is Dr. Chetan Deshmukh. He's an MD and DNB in internal medicine, and he did his MD from BJMC and Sassoon General Hospital, Pune. He did his DM in medical oncology from Tata Memorial Hospital. He's one of the first DM medical oncologists in Pune and from Tata Memorial Hospital. He's a consulting medical oncologist in Dinanath Mangeshkar Hospital, Orchids Breast Hospital, Jahangir, and Ruby Hall Clinic. He's also an honorary oncologist at Sassoon General Hospital. He's the former editor of American Cancer Society, the India Initiative. He's actively involved in clinical research for the past 15 years. He has been the investigator for about 75 clinical trials. I can't see the... He's also the president of Society for Prevention, Healthcare, and... Can you go to the previous slide, please? Yes, thank you. President of Society for Prevention, Healthcare, Education, and Research, that is SPHERE. And I would like for Dr. Chetan to take over and please give the presidential address.
Thank you, Dr. Madhura, for those kind words of introduction. Good afternoon and warm welcome to all my friends, colleagues, mentors, and teachers who have gathered here to attend Synapse 2023, the fourth international conference on mind-body medicine. It's been about 4 years since we started our NGO, SPHERE, which is an acronym for Society for Prevention, Healthcare, Education, and Research. The inception happened a few months before March 2020, and we had our first conference in February 2020, which served as an introduction to this rather important but not oft-spoken topic of mind-body medicine. In March 2020, COVID pandemic struck and things have never been the same again. A lot of organizations had to reduce or even close down their work. And I'm proud and very happy to say that SPHERE continued to work with the same zeal and in fact grew in strength. From providing the much needed N95 masks to healthcare professionals in April 2020, distribution of food grains and medicines to the needy, to imparting education to people regarding physical and mental health, SPHERE continued to work on its motto of tackling health issues at all levels. The global pandemic made people aware of the importance of physical health, prevention, and mind health, especially during phases of those lockdowns. I'm sure all of us agree that those were tough times, difficult times indeed. Synapse conference continued to happen during this period. It happened virtually in 2021 and in a hybrid format in 2022. Another important activity has been the practical and hands-on training workshops in improving mind health and behavioral intervention in clinical practice. Last year, we had more than 100 delegates who benefited from this workshop. Cut to 2023. Today we begin Synapse 2023, the fourth annual event. We decided to conduct this event virtually this year for a couple of reasons. One is I thought that reducing the hassles of travel and staying away from work can help focus on the core academic issues. Secondly, virtual format allows people to access this conference from across the world to participate, to share their thoughts and work. This year, we have people joining from the United States, Germany, and Nepal. After 3 years of a rather troublesome period of the pandemic, we are gradually returning to normalcy. However, we believe that important lessons were learned during this period, lessons which we believe should be built upon, updated, and improvised. Mind health, the link between mental and physical health, concept of allostasis have gained unprecedented importance in the management of non-communicable diseases and in physiological states like menopause, puberty, and in fact, daily living. Sphere has started work in comprehensive global health and wellness assessment, and we hope to showcase our work in near future. We are also working in women health and cancer prevention. The sheer scope of the work is absolutely vast and overwhelming. We welcome collaborations from like-minded organizations, individuals, and companies in their respective capacities to join us in this endeavor. Once again, I welcome you all to Synapse 2023, and I hope you all have a fruitful and learning experience. Thank you.
Thank you, Dr. Chetan, for the wonderful presidential address. I think it was the perfect welcome that we needed to kickstart the Synapse 2023 conference. For our next speaker, I would like to invite Dr. Vaishali Deshmukh, whom we have seen work tremendously hard to make all of the previous conferences successful. Dr. Vaishali Deshmukh is MD, DNB gold medalist in internal medicine, and she has done her DM in endocrinology. She's working as an assistant professor in endocrinology at Sassoon General Hospital and BJMC in Pune. She's the consultant and head for Dinanath Mangeshkar and Deshmukh Clinic, Pune. She is also invited as a faculty for about 932 CMEs, webinars, interviews, and conference. She's the founder and secretary of the NGO Sphere. Her awards include the Gold Medalist Award, the Proficient Woman Award, Kranti Surya Pratishthan Award, Adarsh Mahila Puraskar, Jeevan Gaurav Puraskar. She has 22 publications. She has also authored 4 chapters in 4 books and press, and she has published 60 global phase clinical trials in endocrinology and MBM research. I would like to hand over the mic to Dr. Vaishali.
Thank you, Dr. Madhura, for that kind introduction. And I would like to represent as a secretary of Sphere as to what activities we have been doing, and we would like to reflect on this. So I would like to share my presentation. Can I share my slide, please? Yeah. I hope my slides are visible. Yes. So, as we heard Dr. Chetan mentioning that Sphere stands for an acronym. The acronym is SPHERE, and of which P stands for Prevention of All Non-Communicable Disease. H stands for Healthcare for All. Then E stands for Education of Community, Doctors, Nurses, Paramedics, Organizations, Societies, Industry, and Institutions. R stands for Research in Non-Communicable Disease, Endocrine Disorders, and Cancers. And in this, we have a common motto of women health and mind health coming into all these categories. So that's how we landed up with Synapse. And our journey has taken the footsteps through conceptual framework, operational framework, translational framework, training and education. So we have been working on these fronts simultaneously right from the inception. So laying the concept was a difficult task, and I should thank all the mentors and the patrons who have supported me in this cause right from Synapse 2020. And CBM Trust has been very proactive in terms of taking this concept ahead at various stratas in the society. So these were the three conferences, the Synapse 2020, Synapse 2021, and 2022. So the initial first conference was mainly to lay this concept of mind-body medicine in endocrinology and diabetes, because it was not described in books till then. And even now, literature has very few documentation on this whole concept. So setting a context of getting this concept into the generation which is practicing diabetes and endocrine was the first thing. Second is that how you help the lifestyle intervention in a very practical fashion. This was what was taught in the second conference. The third conference, which was done last year, was mainly focusing on how to improve quality of care adherence. And now we have moved a step ahead in terms of giving this kind of therapy as an adjunct to pharmacotherapy. So we are talking about pharmacotherapy as the therapy for illness and adjunctive therapy of mind-body medicine as adjunct therapy for wellness of those ill patients. So it is like illness covered with diabetes control and wellness of a diabetes patient being dealt with mind-body techniques. So it is like a synergism of these two therapies. So this conference is mainly going to focus on this synergistic combination of pharmacotherapy and adjunctive role of these mind-body medicine. So what concepts have been brought about by Synapse was mind-body medicine, then putting diabetes as a network science disease where integration is a must. Then psychoneuroimmune endocrine model was described first time. And apart from that, we have come up with certain new assessment of health strategies, especially the CGI health, the CGI, the comprehensive global assessment of diabetes, and then the concept of autonomic health and autonomic hygiene. So all these concepts have been the cornerstones on which the organization in collaboration with CBM Trust is working, and Indian Psychiatry Society has been very cooperative in this endeavor. So as I said, this not only was it preached in conferences, it was also practiced in our clinics, and it led to design of two important questionnaires: the Mind Health Assessment Questionnaire, the PNI questionnaire, then the CGI Health Assessment Questionnaire, as well as the CGI Diabetes Assessment Questionnaire. And these four questionnaires were implemented. Their studies are being published for these, and we will have soon data coming out with these studies, which are long-term prospective studies. So what has eventually happened is that we have been able to get into the society, to a general practitioner, the concept that mind-body medicine can be useful right from the primordial prevention level to primary and secondary prevention in terms of improving compliance and adherence to therapy, and in terms of tertiary care, that is improving the resilience and the survival and quality of care of terminally ill patients. So all this, like a pyramid that we usually follow for any NCD, mind-body medicine forms the base of that pyramid, and that is what we are trying to look, that this has to be offered to the masses beyond what we are giving as pharmacotherapy and other lifestyle interventions. As far as the research and the operations are considered, heart rate variability studies are in progress with cardio-autonomic studies, the CGI health, the CGI diabetes, and yoga and autonomic nervous system studies are in place with various collaborators. Now, patient workshops and mind-body clinics have been an integral part of our activity right from the beginning. But first time in an institutional setup, mind-body clinic has been started by Dr. Leena Fadke and Dr. Priya Mardikar in the physiology department of SKNMC Pune. And I think that's a huge success of this whole story. And I would like to congratulate the team on that. In publication are various processes. We have chapters on PNI in health and disease in the ESI textbook, which is awaiting publication. Yoga for diabetes prevention, which is also awaiting publication, and prediction of micro and macrovascular complications in type 2 diabetes using heart rate variability is now sent for publication. So these are the publications which are in place with all the activities that have been done so far. As far as the autonomic health aspect is considered, digital innovative health solutions have been looked into, and with the help of technology, we could come to this concept of this chronovisor tele HRV, which is a digital health solution for easy detection of the cardiovascular risk in diabetes. And this is indigenous. I think it is 1st April today. It's not only April Fool Day, it's also DIY Day. So do it yourself. And this is the first technology in India which is indigenous in nature, which is easy to use, and that whole team involved in this R&D has been useful in designing this technology, which has been very handy and non-invasive in nature and at the cheapest cost. So you can see that this technology is non-invasive, the skill requirement is low, the cost is low, however the sensitivity is high. So as compared to all the other tests which are quite expensive and invasive, we have been able to design this standardized test for cardiac autonomic dysfunction detection. And it's just this handy device, giving us a clear picture of the autonomic status. This data was presented by us at RSSDI Ahmedabad way back in 2018, and now it's a time where we are implementing into the society. It's already been presented in the ESG, and the artificial intelligence methodology using this data has been presented in USA also. The technology has received numerous awards for innovation, and now we are planning to take this technology to every physician and every general practitioner who can assess the cardiodiabetes vascular risk. So coming to the operational framework, the 2-minute mind body health questionnaire was designed by us, and which was published in the American Association of Clinical Endocrinology in 2022. And this questionnaire was forwarded to the team of collaborators, and Dr. Kirti Samudra from our team, Dr. Pradeep Kumar Modi, have designed their own strategies for psychosocial counseling, and we'll be hearing more from them as to how they have taken this ahead. And HRV studies are being undergone for cardiac autonomic assessment. So as I said, that patient education and patient centricity is our goal, and that's why we go to the community every now and then with these concepts. And the reason why we did this fellowship was the same, so that we could take it to the interiors of the country, and we had people coming from all over India, even from outside India, for understanding this concept of mind body health. The first fellowship program, which was done last year, it was well appreciated. It was a 4 days workshop, and this was the first batch which passed out. So this year we have this workshop on 20th to 24th July in Pune, and I welcome all of you to be a part of this. So the future is, what we are looking forward is opportunity for health promotion in diabetes. We're looking at yoga as a neuroscience technology, looking at concept of autonomic health and hygiene, identifying autonomic arrhythmia as a marker of stressors, then corrective strategies to help this autonomic arrhythmia, and to get a uniformity of health assessment and illness assessment in diabetes as a CGI, and making mind-body medicine as an integral part of diabetes and NCD management. Of course, it's not an individual work, it's a team of collaborators who have come together, and it's not only a national team, an international team working in the background. So that's all. And before I end, I would like to say that knowledge is telling the past, wisdom is predicting the future. So this is what we want to share, the wisdom of all the eminent people, and that's why you see the faculty is such that they would be sharing their pearls of wisdom with the whole audience, and I'm sure you'll enjoy that. Thank you so much.
Thank you, Dr. Vaishali ma'am, for that enlightening reflection of the past work of Synapse. So since we are done with the first part of our conference, I would like to hand over
Yeah, so hello everyone for this first session of the Hall B. And it's an interesting session for all of us because it's easy to talk about mind body medicine. But when it comes to implementation, I think we really don't know how to take it into our patients. And I think we have four rather eminent physicians and diabetologists who could take it to their practice. So I think the skill in all these four people lies that they have been able to take this whole concept into the clinical practice. And I think we need to learn a lot from them because it's very difficult to take this concept into the field level. So I would welcome all the panelists for today. Can I have the CV slides? Yeah, so we have Kirti on, I think she's not joined as yet, but Kirti is a practicing physician and diabetologist of Diabetes Care Clinic, New Panvel. She's totally 30 years in practicing and more than 25,000 registered patients, conducts regular education programs for at GP. She's a faculty for the PHFI and NDEP and speaker for regional and national conferences. She is not be joining here, but we have her pre-recording about her activity because she had some commitments. Next slide. So we have a second panelist, Dr. Asmita Deshmukh, ma'am. Hello, ma'am.
Hello.
She's a senior physician from Navi Mumbai, and she's MBBS MD in general medicine, and she's ex-professor Terna Medical College, Navi Mumbai. She's practicing since 2003, and she has been able to take mind-body medicine to a next level in her practice. So welcome to you, ma'am. Next slide, please. Then we have Dr. Pradeep Kumar Modi, sir. I think sir has been the senior most member who has taught us a lot, and we have also learned a lot from him. He is MBBS from Grant Medical College. He is PGP in diabetology from John Hopkins. He has a certification in obesity medicine from the Scope. He's invited to attend the obesity workshop. He has a nearly 40-year clinical experience, 10 years of experience in obesity and weight loss practitioner. He is the faculty for fellowship program in obesity medicine and metabolic disorder at the Hiranandani Hospital, and he keeps on conducting seminars for obesity prevention in schools, corporates, and family physicians. Very humanitarian soul at heart and very simple person with a great thought that I know of. And he's conducted lectures and seminars on obesity management. He has been an active member of Synapse all these years and currently is practicing in Dahanu. And he's a member of IMA WAPI too. So welcome to you, sir. So then we have Dr. Medha Oak. So she is a very good friend of mine. She's done her MD medicine from Mumbai. She's cleared her MBBS and MD from St. GS Medical College and KM Hospital, Parel, Mumbai. She's practicing physician and diabetologist since 1993 at her Oak Hospital in Dombivli, East Thane. She's attached to JK Women Hospital, Icon Multi-Speciality Hospital, lecturer in medicine department at the College of Physiotherapy, Dombivli. She's trainer for NDEP and she's conducted special program for diabetes awareness, especially in lifestyle modification for women and senior citizens. So thank you, Medha madam, for being here. So now we have, can I have this screen now?
Yeah.
Yeah. So this is going to be a panel sharing of experience of how the mind body medicine strategies that we have learned, discussed, and have heard of over years of Synapse. How they have been implemented by each one of you, because though the knowledge shared has been the same, I have realized that people have implemented with their own intellectual categories and they have made it much more than we had expected. So I think they have taken it to a next level. We wouldn't have imagined that they could have done all this otherwise. So I would like to ask each one of you. I would begin with Asmita madam, then Medha madam, and then Modi sir, as to how have you implemented these techniques in your own practice. Who would like to start first?
Hello.
Yeah, hello, Asmita.
Yeah. I have implemented. See, this was a thing in my mind since so many years, but how to implement was really a very big question, because there was no parameters as such except for the, I think, blood sugar levels and weight recording. We did not have any parameters to see the improvement of the patient. So this mental aspect and all this, it really helped by mind body medicine parameters, whatever rating scales which we are measuring in the form of vitality, these 4 factors and 4 factors in the psychology. This is really helping us, because now the asking to the patients have become very easy. They know, sometimes even patient don't know what they are suffering from. When they read through it, they realize that it is what they are suffering from, and they are able to rate it. So that I find this mind body medicine has very big input in the form of rating sheet, the clinical global this CGIH scale which we are using is really helpful, not only for the doctors, even for the patients. So this form filling is the best thing which we are doing in our clinic.
So you could get some forms to be filled by patients, and then
that is
so
what I'm presenting now. That should I present?
Okay.
Start?
Yeah, sure. Why not? You can share your screen.
Yeah. So
That's an excellent feedback that you.
Yeah. So most of the time, actually, I was talking with my patients regarding food, intermittent fasting, lifestyle modifications, exercise, inch loss, yoga, and meditation. But really, I did not have any scale to measure whatever improvement the patients are making, or whether I am able to reach out to them properly in a graded manner. And the only thing I was recording was their good his fitness level, glucose levels, and weight recordings. So this scale has given me all the inputs which I wanted to share with my patient, and I want my patient to share with me. So, and therefore I'm very grateful to MB Mind Body Medicine and Synapse team for this. And especially I thank Dr. Sanjay Phadke for giving me the confidence to write the drugs for sleep and anxiety disorder. That was a very good input, and so many of my patients are doing very well with the drug 81 1 milligram which he has suggested. So here I want to share my experience with you all. Actually, while giving forms, I made few shortcuts because experienced some difficulties with few of my patients. So especially this mind positive psychology, they were finding it difficult to understand, and they were overlapping it. So I clubbed the psychological insight and the comfort level of comfort. These two things I clubbed, and I made certain points in their form so that it will be easy for them to fill. Still, only full forms were filled only by 16 of my patients, and 10 patients filled only few columns, and they refused to acknowledge it, and they refused to discuss it with me. Many patients outright refused to fill the forms. I don't know why. So, but when we tried to ask them, so they don't want it. They don't want to spend extra time. They don't want to address the problem which they are suffering from. They may be in denial mode. They say they don't have any psychological issues which are mentioned there. Found it rubbish. Some says their data will be leaked for the trial purpose. So they refused, and I did not force them to fill the form. I have given them forms at my reception. So my receptionist gives them form, they fill it, and then they come inside the cabin and we both discuss. So many times I have realized that I have to help them to fill the form, because so many things they are not able to understand regarding their comfort zone or psychological issues, or what do I mean by, psychological well-being or sleeping peacefully. What I want to know about them, they don't understand. So they ask me that this is what is there with us, so whether it will be in point 1 or it will be in point 2. So that is how we were discussing. And after discussion, the form I have kept in their files, I've attached to their files, and I asked them that this form, they will fill it again side by side when they will come back again after 3 or 4 months. So out of the 16 patients, only 3 patients came back after filling the form to me. So female patients were more forthcoming and eager to discuss their issues as compared to male patients. That may be partly because I am a lady physician, so they are feeling free to talk to me. And many of them even needed my help in filling the form, and I was very ready to help. They were very unsure about their psychological health and about their sexual health. So I helped them there, and I don't have any big setup. So problem is I don't have any counselor around. Therefore, I have to spend extra time with them while discussing all the points. If my more patients are enrolled, so I'm planning to hire a psychologist who can come once or twice a week to my clinic and can take sessions for 5 to 10 patients together. So it will help the patients also, and I will get the good feedback, whatever a real feedback from the counselor, and it will help me in deciding the further course of action. So, and it will be easy for me record keeping also. So now, out of the 16 patients, what I have realized is maximum problems diabetes patients felt were related to their sleep, partly because of increased frequency of micturition or dryness of mouth or itching or sleep apnea. And rest of them maybe because of stressful working conditions or painful relationship due to erectile dysfunctions or generalized weakness, lethargy, mood swings, or inability to cope up with the office and family timing. So 77% of them had sleep issues. Regarding fitness and vitality, only patients who were engaged in regular physical activity, that is 5 to 6 times days in a week, able to feel fit and energetic. Out of 16, only my one patient was at the level of 1 in the rating scale. Rest of them either 2, 3, or 4. During form, I feel these patients, they need more motivation to engage in regular physical activity. They tell so many reasons for inability to do any exercise, but I feel the membership to the good fitness center is the need of the hour. And not only that, the trainers especially should be trained to manage the diabetic patients, because they should be aware of about their hypoglycemia, ketosis, dehydration, and autonomic neuropathy, which is not seen in the trainers. They are only busy in weight loss. They don't know anything about that the after exercise what a diabetic patient needs, and he may land into hypoglycemia. So I feel that is the problem so many of my patients told me when they go to the gym. And all functional exercises.
So, sorry to interrupt you, Dr. Asmita. Do you feel that asking these questionnaires have helped patient come close to you in terms of opening up?
Much.
Do you feel that?
Yeah, very much. Very
so,
much.
can you just give us some example, like how people have opened up to you after these questionnaires have started in?
Especially one patient who came to me with the HbA1c of 11.3%, and there was no family history at all in her family. There was no reason, and she was shifted recently from Odisha to New Bombay to her daughter-in-law's place, and daughter-in-law brought her to me because of her tinea cruris. So when I saw her reports, I asked what is the reason. Daughter-in-law was clueless. So I asked them, because she had a language problem, that lady, I asked daughter-in-law to fill this form along with the help of her mother-in-law. The next time, the patient opened to me that it was the husband died 1 year back, and after that she was feeling low. So I told her that you are at the age of 54 now, you should able to cope up after 1 year. Then she told me that it was not a natural death, it was a suicide. And she was not able to tell this to even her daughter-in-law. So the only after filling the questionnaire, she realized that I really want to look into her psychological aspect. Probably this was the reason that in the next visit, she opened up. And now I have referred her to psychiatrist, and she's really doing well. So this was a very nice example for me, because that lady came to me just twice and she opened to me. And
yeah, so I think that's a excellent strategy that you have started looking into objectivity of mind health through documentation of that. So I think just talking to people openly on how you are feeling, instead of that, people are more comfortable opening on paper, and that is very easy to read. and identify even in our practice. So I think that's one thing even I have learned through these courses and through these conferences. So what about you, Dr. Medha? What is your experience in use of mind-body medicine in diabetes? You're muted, Dr. Medha.
Am I audible?
Yeah, you are.
Um, I would like to say a few words before I give some examples. Like, first of all, I'd like to thank you all for inviting me for this session. And like filling of the forms was not possible for me in my clinic. But then all the points were registered, which were never asked by me in the beginning. Right. So I'd like to first just 2 minutes talk about it. Like mind-body medicine was a well-known idea to us. This connection was taught to us actually in the early days of medicine, and much before like our grandparents and parents used to reassure or give confidence, creating comfort zone, positive thinking. But in the initial days of practice with few patients or enthusiasm and no time constraint, we used to talk and establish a relation with the patient with an ambition to establish in the practice. And at least we all did a bit of this mind body medicine practice during that time, like giving emotional support, empathy, sharing their sorrows, or patiently listening to their stories and giving some feasible solutions. And that would really help the patients. And that too with some authority, like self confidence of being a doctor or something. But as the practice was established, or you get more number of patients indoor, outdoor, or you work in multiple hospitals, and then finishing the OPDs or rounds becomes a priority. And in this agenda, unfortunately, not intentionally, this mind-body medicine concept is left behind. So this is my personal experience in last 30 years. So this was a rejuvenation for me, like I could get back something from this conference. In addition to this, nowadays the patients are also in a hurry, coming without appointment or squeezing themselves into busy OPD, refusal to sleep or anti-anxiety medicine, doing all Google work because they are addicting, or refusal to go to a psychiatrist also if we advise. And in addition to that, the physician's fear, which I really had, of prescribing these medicines in a view of addicting pills. So I was really worried. And that's why this connection of mind-body was lost. So I think after joining this program, attending sessions with Dr. Phadke and Dr. Vaishali Deshmukh, I made some changes in my practice. I decided to give some time for the patient, at least 2 to 3 minutes more, and then find out their stressors, sleep patterns, and convincing them to take a pill for their stress, anxiety, or panic disease. And see the results in a very few days, like 10 or 15 days probably, with the lowest possible pills. And in fact, I read again about alprazolam, lorazepam, everything before prescribing Valium and all those things. All benzodiazepines to be for my like confidence. And to my surprise, 60% of the patients where I asked for sleep disturbance, they did say yes. And in fact, out of those who said yes, 60% agreed to take a small pill, small dose of tranquilizer. Like Dr. Phadke told, half a pill or 1/4 of the pill at bedtime, and check the results within 15-20 days. And I did try a small dose of tranquilizers like alprazolam or lorazepam. And I would really like to tell you like real life experiences which I had following these things. And there were people like who have continued it, feeling much better on reduced dose of diabetes and hypertension, and they are much more happier than they were before. So I had one patient of severe sleep disturbances following with me for years together. He used to come every 3 months to see me, check his sugar, check his BP. And mind you, all the reports were good. So after this mind-body medicine session, I did his ABPM to gain confidence, and it was also good. And this time, I sensed that he is not sleeping well. and he needs a good sleep to reverse his diabetes and blood pressure. And to my surprise, I was able to convince him with a small dose of tranquilizer, and he took it for 1 month. And I'm happy to tell that we have stopped his metformin, which he was taking for diabetes, and small dose of amlodipine 5 milligrams he was taking for years together as a psychological support for his BP diabetes, because he had a scare of those disease. So now currently he is sleeping well. He is on almost alternate dose of small dose of tranquilizer and no medicines for diabetes and blood pressure. Then
I would like to also bring, sorry, Medha, for interrupting. I think here we as diabetologists tend to forget that brain is an important organ for causation of diabetes also. So not only does it require glucose for utilization, but brain itself can be one of the machine to produce more glucose. So more you think, more your brain is active and continuously not sleeping. It's a stressor to the body. So the concept is not to prescribe a pill only and make them sleep, but concept is to heal that organ, which is actually at dysfunction. So I think
I joined yoga sessions for yoga nidra, and now he has reduced the dose of pill also. So now he's feeling really healthy.
And that's a real good experience.
Yeah, but this time I was able to convince him to take a pill, tranquilizer, because I was constantly telling him you can go away without medicines, but I was not giving him any alternative.
Didn't you try referring this patient to a psychiatrist?
Yeah, I told him we can stop your medicines. But then he said, if I sleep too much, I'll lose my job. So it is better to take metformin or amlodipine and continue with you.
Okay, that's right.
Sorry,
yes, Asmita.
4 of my patients turn out to be with the self-control, this rating scale. I could diagnose 4 alcoholic liver diseases. So the 4 after 16, 4 were. But because we always ask about the alcohol history or addiction, in a very casual manner, they say yes, we take alcohol twice a week, thrice a week. But in this, you have to write down that how many pegs, or whether it is causing any stress, or with your functional capacity is reducing. So this mild, moderate, and this level I could diagnose them, and I switched them to the insulin. I have asked them for their LFTs were also deranged. Now I have asked them, they have not come back after 3 months. So I would like to see whether how much I could revert it back.
Okay, go ahead, Veda. Yeah. You were saying something.
There was one similar case, like middle-aged perimenopausal woman who had planned for early retirement due to job stress. What she was thinking, son was in US, so she had only son, and recently lost her father. So she had come with palpitations, raised blood pressure to the tune of 150, 90 at home or in clinic. She had loss of interest in the surroundings, and she could not go anywhere because of long working hours of the job and illness in the family. So I would just reassure her that you don't have anything, and your blood pressure is okay, your blood tests are normal, so you don't need anything. And we also did our thyroid test just to rule out. So she kept on coming to me after every month saying that she is not feeling well, she is not well. And in between this course, I attended mind body medicine thing, and I said, I should be able to help you with something. And I gave her a small dose of mood elevator. I counseled her for quite long, like 15-20 minutes with all her stressors, and her decreased sleep and her complaints of extreme weakness, what was not physical but related to sleep, that I could convince her. And along with lifestyle medicine, like lifestyle modification, what she was already trying to do, I added a mood elevator and anti-anxiety, and I called her back after 20 days. And to my surprise, she was almost 60 to 70% better with these medicines, not any medicine of anti-hypertension. And I could give her some small solutions of that. And now after taking like leave for 2 or 3 weeks from that job stress, now she is even not planning to take retirement because she is just 52-year-old. She said, I'm I think I will be able to continue for another 6 years till 58. And she was very happy because in this 2 weeks she could meet her sisters at Pune, where she was even not able to go. She could go out for movies with her friends. And like this was suggestion on my side. So I said, Ki, you are the priority now. You leave aside all the in-laws in the family and all this thing. You're feeling low because you're alone. And I think she's better organized now in this last 2-3 weeks because of good sleep and mood elevation. And I think she's ready to go back to her job from 1st of April, I think. So
I
was
think
very
Medha
happy
has
with her. Yeah.
Yeah, Medha has put a very important point over here, that the concept that people feel mind-body medicine is alternative is totally gone when Medha is talking about this case. It's like so much of an adjunct that you're giving certain techniques, you're giving the pills, and you're helping the patients to get rid of their concerns, whatever it is. So it's like mind-body medicine is acting as an add-on or as a synergistic mechanism to all the medications that we are prescribing, and we are not being psychiatrists, we are not playing a role of psychiatrists, we are just helping that temporary, you can say, a crisis of mind health, that by giving that little bit of dose that you are giving with anti-anxiety or so I think these are perfect examples in diabetic practice, and we would like to hear more from Dr. Modi also. So Dr. Modi sir has also been very active in this whole concept. So I would like to come again to all of you all to give your views before we hear with Dr. Modi and Dr. Kirti.
Good afternoon, madam, and good afternoon, all the ladies. I
Yeah.
am Dr. Modi. I am from a rural background. My patients are less educated, financially poor. So after attending this workshop at Pune, I have realized that you cannot treat the disease itself physically. You have to concentrate on mind also. And your approach has to be holistic as far as the treatment of chronic disease, especially the endocrine disease and the diabetes is concerned. So first thing I did is I put a board in my clinic. गुस्सा करना मना है, no anger zone. Second thing, I started coming little earlier to my clinic by 15 to 20 minutes so that I am well prepared. I say good morning to my staff. I say good morning to my patients also. So that moment I enter the patients, they start getting familiar with me. New patients, old patients, they all realize that in the clinic, after see, I do not have a separate staff to take this history, and also all this history, everything is taken up by me only. And I take the history in brief about this psychosomatic illness or any past history of emotional problem or any mental trauma. And moment I feel that there is any clue, I go into the detail, take the detailed history and keep it on my notes on the case paper rather than keep filling up the pro forma, because pro forma filling becomes little mechanical, is what I personally feel. So you should concentrate on the case-to-case basis, take the detailed history. And I have found that each and every patient of endocrinology and diabetes has got some point of this thing, that he has got a psychosomatic problem. Whether it is mild, whether it is moderate, or whether it is. So your approach has to be holistic. The physician, we were not taught mind-body medicine during our educational curriculum in medical college, and it is not even taught till today in the medical colleges. But this is the right time where our approach has to be combined physical as well as mind-body, both together, mind and body together. Then only we can have good results. Otherwise, treating the patient physically or illness-centric approach and approach to the biochemical results like your BP, your cholesterol, your diabetes, your HbA1c is not going to solve the problem. Because ultimately, we control the disease. We don't cure the disease. We prevent complications, but we don't cure the disease. And all the patients having this chronic disease has got some component in their mind, some negativity, some thoughts which aggravate the disease, which modifies the disease, and which leads to multiple problems. So that I learned, and I started implementing this. And I have got so many results showing that mind-body is a total component. You have to treat the patient in total. You have to treat the patient holistic approach. Then only you can treat the disease. Because what the WHO says, it is a state of complete physical, social, mental, emotional well-being, and not just merely the absence of disease. So we are not treating the patient to take care of the disease. We are treating the patient to have the wellness. So in the spectrum of wellness and illness, we have to take wellness side first and illness side together. Then only we can show the results on long-term basis. Otherwise, we are just controlling the symptoms. We are controlling the blood sugar readings. We are controlling HbA1c. But ultimately, that is not going to happen. Meditation reduces medication. That is my mantra. That's what I learned. And I can share few patients as far as this, what Dr. Mehta has said. There was a lady, 52 years old lady. She was brought to me by husband and daughter. And that lady, throughout my discussion for half an hour, she did not utter a single word. All the story, all the details, everything was told by the husband and the daughter regarding her illness. She had uncontrolled diabetes since last 3 years. And before that, her diabetes was reasonably under control with medication. She was under 4 medication, including insulin, basal insulin, and the blood sugar was not under control. Then I could realize that there is something wrong with this lady. Why she is not speaking out? So I asked the husband to wait outside. With daughter, I talked to the lady, and ultimately I found out that one of her daughters, she developed a premature child, and the child was serious, was admitted in a corporate hospital for 40 days, and they spent the bill of around 14 lakhs rupees. And that was a big trauma to the lady. And after that 40 days of illness and after spending 14-15 lakhs of rupees, the child could not be survived. And that added and multiplied the trauma, mental trauma to the lady. And that was the reason of uncontrolled diabetes. So I did a counseling. I sent her for mind-body techniques. And slowly and gradually, she started mixing with the family. She started talking to the husband. She started talking to the daughter. And after 1 month, when she came to me, she was little friendly. I did a lot of counseling, a lot of encouragement to her. And within a period of 3 months, her blood sugar started coming down. She was feeling little fresh. She was talking nicely. And after 4 months, now her blood sugars are controlled with 1 or 2 medicines. She is happy. The family is happy. And that is the result of mind-body medicine.
I think one important point which Dr. Modi has highlighted is that you can't treat endocrine and chronic diseases on lines of biomedical model only. So you treat sugar is high and you treat sugar, that can't happen with diabetes. You have to treat it on lines of a biopsychosocial model. So you have to treat the psychology, you have to treat the social aspects, and you have to treat the biology of the disease. So I think all of you have highlighted the importance of understanding mind-body medicine on a different scale altogether, and how you all have been able to take it to your own practice. And I think if you can compile all these cases, it will be a huge spectrum of diseases that you're just treating with a proper counseling, with proper identification, proper pill medication dose. So before we come back to all of you, we will hear what Kirti has to say, what she has done in her practice. So can I have Dr. Kirti's recording? She could not unfortunately join us today because she's traveling. But if we can have her video, by that time we can hear what she has implemented in her practice. So the backend team, can you help me? Darshan, can you help me on?
I'm Dr. Kirti Samudra, and I have been attending synapse and mind-body medicine since last 4 years. Today, I'm going to share with you my experiences and how this is actually getting me into my practice in a different way. We all know that mind-body medicine is a very important thing, and our patients actually always want to do that, because we see our patients going to such kind of some places where they get all these things under one roof. They go there for 3 days, 7 days, 15 days. They feel very good. They feel that their sugars have come down, their blood pressure is normal, and they're very happy. But later on, once they are again back into their routine life, everything changes, everything goes haywire. So why not we doctors who are treating diabetes, obesity, hypertension, all these metabolic disorders, why we should not work on this, and why we should not help our patients to take care of their mind so that their body remains healthy and their all metabolic problems are under control. This is the main aim of this mind body medicine. And actually, even after conferences, this year's residential workshop on my mind body medicine has given me a lot of insight. And after that, I really decided that yes, I have to do something for my patients. And for that, learning through all the types of how we should get the feedbacks from our patients, giving them some forms. Like in this residential workshop, we worked upon CGI, that is clinical global impression, CGI of health, CGI of illness, CGI of about nutrition, CGI about all the metabolic illnesses. But giving these forms, taking it from our patients, getting their feedbacks, and then learning something from that and giving them the solutions, it takes a lot of our time from our practice. It is very difficult for us to spend such a time for our patients to understand all the difficulties and to understand their mind body connect. So, but to a large extent, giving such forms and then studying these, they are very important. So taking help from Dr. Vaishali Deshmukh, I also designed a form which for the first time this year, I gave it in a large gathering of our patients. I do conduct one patient education program every year on World Diabetes Day. So this World Diabetes Day on 14th November, I gave such forms to all my patients who attended. There were some of them were patients, some of them were healthy volunteers also. Those who means this, I feel it will help us in for diabetic patients to manage their diabetes well and to prevent the complications in them. And for other people who are still not diabetic, we can do something to prevent diabetes or prevent all these metabolic problems. So give me a second. I will share the form which I used this year. So this is the form which I got printed and I distributed. Almost we gave 320 number forms to the people who attended this, and we unfortunately we didn't get all 320 back. Around 195 people filled the form and returned it to us. So it's very simple. The first page was like when they were detected, whether they know something about diabetes. This also gave us insight that how much they know about their disease, what type of diabetes, what medicines they are on, and already if they have some complications develop. Then I tried to assess on the self-efficacy scale, so how much they are confident to do certain activities, like how confident do you feel that you can follow your diet, or how confident you feel you can exercise for 15 to 30 minutes, 4 to 5 times a week. How confident do you feel that you know what to do when blood sugar levels go high or low? Then how confident do you feel that you can control your diabetes so that it does not interfere with the things you want to do? And how confident do you feel that you can judge when the changes in your illness mean you should visit the doctor? So very simple questions, but what we did, we explained to them because it was a large gathering, everybody was sitting. So we explained the questions and we tried to get the answers. Then there was one more sheet where, again, for assessment of the patients, their own emotions as well as whether they have some insight, like do you feel irritated, sad, or do you feel depressed, disinterested? Do you have any problem in concentrating? Do you feel your interest and enjoyment in activities has reduced? All these types of some around 10 questions. And later on at the end, we tried to assess self-rated health, like whether patient feels that how the health is, means that person's health, whether he or she feels it is excellent, very good, or fair or poor. And as I told, we got 195 responses. And self-rated category, we found that amongst diabetic patients, they felt 30 people were rated it as excellent, and almost only one person as poor and 17 fair. But after all the forms which were evaluated, later on we thought that almost counseling was needed. Amongst excellent also, 13 people actually were requiring counseling. People who rated their health as very good, 26 of them were in need of counseling. So if we see like this, definitely there is a need. Patient, even if they are not realizing what kind of health they are going through, but they need counseling. We tried to contact them, we tried to call them back, but only around 18 people responded out of these 121 people who were requiring counseling. Out of them, 10 people agreed to come, and only now 4 people are actually coming for different things which we are taking them in personal level. First thing which I did was I appointed one person. She is a lady, Dr. Sunita Deshpande. She is helping me in this, and she is sitting with the person in personally. We tried to take them in a group, but it was not possible. People were not willing to. And now what I'm doing is, every day I'm getting these forms filled when people are waiting in the OPD, and we'll try to analyze. By the time this year's workshop is done, I think I should be having good number of forms filled so that we can have something. So there is a possibility we can do some research work, we can publish a paper, and all with the help of this mind-body medicine and Dr. Vaishali Deshmukh. I think we all can do a good job, and definitely I will try to do more by the time this year's workshop of mind-body medicine is there. Thank you for giving me this opportunity for sharing my work, and with the help of mind-body medicine, we will do some good work. Thank you.
Yeah, so I think that was Kirti, and I think she's done a wonderful implication of what mind-body medicine can do in practice. So she's trying to convert this into what we call individual physicians and general practitioners can become researchers when they work in mind health, because they are the closest to the patient, and the people don't open out to super specialist or endocrinology practitioner, and they will agree to giving these kind of information. So that was very interesting to hear that people can be risk stratified based on how significantly they are affected in their mind. So these are you need not pay attention to mind of every patient. You need to actually see which patient needs more of attention, and those patients can be then counseled or referred to the psychiatrist where required. So I think we have another 10 minutes. I would request each one of you to give your own take on what should be the next, what would be your suggestion for a physician or a diabetologist who is practicing diabetes? What should you take care home as a message from Mind Body Medicine as a group and through your practical opinion. So beginning with Dr. Modi now. So Modi sir, your view on what should be the take home for physicians attending in the audience?
Thank you, madam, for giving me the opportunity. My first message will be keep a holistic approach and not the illness-centric approach. Number two, try to study and analyze the root cause of the disease by talking to the patient, talking to the relatives, and find out whether it is only the physical aspect of the disease or there is any mental or any psychological aspect of the disease also underlying, which is hidden. Number three, there is no medicine for every disease, and many of the medicines, they create disease.
Yes.
We try to cure the disease with medicine, but many a times medicines create disease, like complications, heterogenic disease. So try to minimize medicine as far as the treatment of the patient is concerned.
So judicious use is what you're talking about.
Yeah,
it should not
judicious.
be, yeah, it should optimize medicine usage.
The
Yes.
practice is you prescribe one tablet, blood sugar is not under control, patient comes next time, you will prescribe one more medicine, patient doesn't come under control, third medicine, fourth medicine, but without finding out the cause, that what is the cause which is not controlling the blood sugar.
So
if you take care of
going to
that
the
part,
root of the disease.
yeah, going to the root cause of the disease. Then meditation reduces meditation reduces medication. I advise all my patients who has got any psychosomatic illness, any disease whose blood sugar is not under control, BP patient not coming under control, I advise them to do meditation at least 10 minutes, 15 minutes a day. And that gives excellent result. I have done a trial, which I will not be in a position to elaborate now, right now, but we may discuss it sometimes later on. And practice 5 pillars of lifestyle medicine, that is diet, physical activity, proper sleep, stress reduction, and avoid addiction of tobacco and alcohol and smoking. These are my 5 mantras.
What about you, Dr. Medha?
Yeah, I found like investing emotions in others can help them. And like Dr. Modi said, even I've started going a bit earlier to my clinic so that I can spend more time or give some frequent visits to the patients who really need it. And now I've told them one sentence like, fear and anxiety is a thief of your joy. So that is one thing. All lady patients, I tell them that self-love is equally important. You should care for yourself because all the family relies upon you. And like I also conduct some programs for women or senior citizens. And this time, like just talking about diabetes or lifestyle or exercise, my topics definitely changed this time. I spoke on mindful eating, eating at the right time, and I spoke on sleep disturbance. So the sleep disturbance was highly appreciated by the people. And they said, no one asks us about our sleep whenever we go to the doctor. So I think that was a pitfall. So I could recognize that because of this Mind Body Medicine conference. So I was happy to talk with the patients. And I think talking out becomes very difficult, interesting nowadays with the patients. So they open up to you very frequently, being a lady, or if they've already followed up with me, I think with my questions, they are eager to answer all these questions regarding their sleep, anxiety, fear, and just talking out also has helped quite a lot of my patients. They tell me, now I'm feeling much more better when I'm leaving this clinic today. So I think that was really fruitful for me. And I think we should ask more and more questions in a good format to patients, I think in the beginning, and keep on evaluating them at every visit or at least 6 monthly.
So not offending them and still being politely kind to them and getting their mind opened up. That is very important.
Yeah.
Yes, Dr. Asmita, what about you? What is your take home for the audience today? You're muted, madam.
I have changed my prescription. Now my prescription starts from daily 1 hour exercise. Previously, we used to write only strict diabetic diet. Now, sleep for 6 to 8 hours, daily 1 hour exercise, and stress-free yoga and meditation. So I think when we write these 3 points on top of our medicine, it creates an impact on the patient also. That is what I felt. And very important is, as Dr. Medha said, the sleep disorders were the thing which we were also not asking before this in a very detailed way. But now I have started asking not about even sexual health. Beyond erectile dysfunction, hardly we used to ask anything to our patients. Now we are asking all the details, especially lady patients. As I told you, female patients are opening up very nicely to us. So this is helping us in treating the patients, because I feel half of the time, most of the time, the stress is the main factor. And the surge which we see in the sugar levels, that he was controlled properly 2 months back, and suddenly in last 15 days it has deteriorated. Every time it has to do something with the stress level. Hardly it has to do something with the food. I have realized that you are attending marriage once in a month, but whole month your sugar was high. So I realized the stress was the main factor. So now I am also giving more emphasis on the stress, sleep, and the main part was digestive disorders. That also, unless and until patient used to tell us that he has a hyperacidity and all that, diabetic patients, only when the patient is on wo sweet L that you may feel bloating or you may feel distension. Otherwise, now in this format, the patient is able to give us all the detailed, history. So ANS evaluation has also become easier. So
I appreciate that you brought out that point, that autonomic health is also to be spoken to diabetic patients.
yeah,
And I think very well said. And I take some key points from all three of you. I think Dr. Modi had that non-anger zone. I like that concept. Then I liked Medha's sleep concept and talking to patients. So talk and listen to them. And I like your prescription change. I think even if doctors are able to carry the prescription with all these things, and Kirti has given a new venture that you can do apart from your clinical practice. You can collect data, you can advocate the need of mind-body medicine more to the needy people. And I think that's what there is the success of all these programs over the past 4 years. I think even if one patient has benefited from all of you, we have done a lot of good to all these patients. So anybody else has some final comments to make? Yes, Dr. Modi.
I would request all of us to include mind-body medicine as a curriculum at undergraduate level as well as postgraduate level in medical colleges. Because this is the need of
I wish the government officials are listening to this meeting. I wish. Yeah.
Let us hope for the best, madam.
Yes.
at least nowadays they are talking about communication skills in the endocrinology.
Yeah. This we used to learn from our bosses directly, like a blotting paper. So we never had a chapter on communication skills.
Okay,
Yeah.
but for the information of all of you and our audience, we have a nice talk on sleep by sleep medicine expert Dr. Karuna Datta. We have a nice talk on sexual dysfunction by Dr. Baspure, and Dr. Gangadhar sir is going to address us on how government policies are now shifting towards more of mind wellness. So shifting from illness centers to wellness centers. So that's what he is going to address. So I think we are on the right track, and I am so glad that you have been so efficient in taking this to practice and helping your patients in your own way and in own capacity. So anything else to be said? I think we are dot in time for the program.
We are polishing our practice now.
Yes, I agree with all of you.
Thank you very much, madam.
Like to
Whatever we have learned under your guidance.
Thank you so much. Thanks. It's my pleasure to be here.
Form should be made slightly easy and small. The point should be less. Sometimes seeing so many points, patient don't try to feel it. So if the points are less and that psychological aspect, I think should be compiled so that it's easy to fill. Because those who are not literate are finding very difficult. much difficulty in feeling
I think that the
physiological.
general practitioners are in best position to tell what are the key 4 or 5 points which you need to
Yeah.
ask the. So we would welcome all the practitioners and physicians to let us know, and we can definitely help them out.
Yeah.
So I think thank you all for being here, sparing your
Thank
1
you.
hour of time.
Thank you.
And thank you, Dr. Modi, Dr. Medha, Dr. Asmita, and the whole team, including Dr. Kirti, who's not been able to be here, but she's been very proactive with the group. So thank you. And now we are going to move to Hall A for some time because we have a presidential address and keynote over there. And then we are going to come back. I think Dr. Shetkar sir has joined. Welcome, sir, to the meeting. And Dr. Shetkar sir will be moderating another interesting session on aches and pains, which is mainly in concern with psychosomatology of rheumatology. And that's how we are going to go to another aspect from emotional pain to physical pain and vice versa, both. So thank you so much. So we meet now in Hall A, and you'll have the Hall A links or the delegate link, whichever you can join. Thank you so much.
Thank you.
Thank you. Thank you.
Introduce Dr. Arun Barwale, sir. Can I have a CV slide, please? Yeah, so sir is professor in psychiatry at MGM Medical College and Hospital, Aurangabad. He is the vice president, come president-elect for IPS West Zone in 2022. Then he is the member of Board of Studies of Medicine and Allied Subject in MGM IHS. He's an ex-honorary treasurer of the IPS. He's the ex-member of the Board of Studies of Psychology, Aurangabad, organizing chairman of PGCME West Zone, Aurangabad, the organizing chairman of NCYP Aurangabad, and organizing secretary of Midterm National CME. And he's been very proactive in organizing sign-ups with us and with Niemann's Bangalore too. So over to you, sir.
Thank you, Vaishali ma'am, for giving this opportunity, for moderating this session of Synapse 2023. Am I audible? Hello?
Yes, you are audible.
Yes, sir, you are audible.
So this session is basically inaugural session as well as a message from our very senior director, ex-director of TIMHANS and presently chairperson of NMC, Dr. B.N. Gangadhar sir. Actually, Synapse is this is the fourth year we are conducting under guidance of Vaishali and her team. And the very first was a big success, which was in physical form. Because of Corona, 1 year we could not do that. But later, consecutive, this is the third year we are able to manage Synapse. So this year, she has given very nice topics. So let us have introduction of Dr. B.N. It is not necessary actually. He is known to almost all of us, but still, as a formality, I would like to say a few words about him. He is president of National Medical Commission of NMC, New Delhi. He is former director and senior professor of National Institute of Mental Health and Neurosciences, that is NIMHANS, Bengaluru. He is honored by the President of India in 2020 with Padma Shri for the contribution to the mental health sciences. He is fellow of Indian Academy of Medical Sciences, Indian Academy of Sciences, and Royal College of Physicians, Edinburgh. He is member of International Brain Research Organization, BRO, globally renowned researcher in neuromodulation interventions, served on the editor board of several international journals. He pioneered the neurobiology of yoga research, further father figure of integrative medicine of India, and patron of mind-body medicine. Basically, he has started this integrative medicine in NIMHANS, Bangalore. It's a separate department now. One of our speakers is now HOD of that department. So let me have the first slide, please. CV slide. Hello. Oh, yes. So let me hand over this to our respected B.N. Gangadhar sir.
So should we have the lamp lighting before we start with sir's address?
Yeah.
Yes.
So I request all the dignitaries to be there for lamp lighting, particularly B.N. Gangadhar sir, Vaishali, and other team.
I would request Dr. Shashank Joshi, sir, who is our orator for today, Then Dr. Patwardhan sir, who is the Maharashtra Endocrine Society President, Dr. Sanjay Phadke, CBM President, Dr. Chetan Deshmukh, Sphere President, and all the other dignitaries, including the faculties, to open up their screen and be present on screen for the lamp lighting. So welcome to all of you, and we are honored to have you all. Dr. Gangadhar had prior commitments, so he could not be here. So he had a nice half an hour recording of his done yesterday with us. And I'm thankful to Dr. Gangadhar sir for his time spent and mentoring our whole group. So the Darshan, can we have the lamp lighting to begin with? Thank you so much. And you can now start with sir's message, Dr. Gangadhar sir's message.
At the outset, let me thank the organizers of this symposium, Synapse, on mind-body medicine, for inviting me to be in the either inauguration or one of the meetings to share my thoughts on this subject. I understand this is the fourth meeting. Heartiest congratulations on this event. We just had Sri Ramanavami with the blessings of Sri Lord Rama. Let me start to share some of my viewpoints on this issue. The growth of medical science has made an impressive impact on the overall health of the community. We have efficiently curtailed many of the infectious disorders, although one or two of them continue to haunt us, hoping that with the drive that has been put on tuberculosis, by the coming 2 years, we would have contained it. A few other viral diseases, and recently what we went through, the COVID, will perhaps haunt us now and then. Although our machinery is very efficient to contain these disorders. So that's it about the infectious disorders where we have made a great impact. We have had the best network of what we call as the primary health centers and health services at the primary care to be able to reach out to everyone at the earliest and contain the disease progression. Early intervention has been possible, although we have a lot of scope to improve upon it, but we have moved from a grade 0 level before the independence to phenomenal heights in terms of providing healthcare services. Multiple health insurances have come up at state level and at the center level. The recent one by the center, the Ayushman Bharat scheme, is something that is going to make it will be a game changer in terms of providing healthcare and containing the costs from one's pocket with respect to acute illnesses which he will or she will reach for treatment at the hospitals. Containing the infectious diseases, reaching out to early intervention, but yet there is a big chunk of diseases which have cropped up in the last maybe couple of decades. What we have been talking about, the non-communicable diseases, which is something that I would say the bread and butter of most of the physicians, psychiatrists, and a few other groups of people, specialists, where we have to handle many of these conditions, the metabolic disorders, psychiatric disorders, cancer, and of course, susceptibility to infection, and most importantly, age-related disease conditions of the nervous system. These, as you know, that the longevity has increased, and correspondingly, the age-related, not just the brain disease, many other physical diseases also are going to be seen more often. I'm not saying that old age is a burden, but nonetheless, the change of demography, we should also be prepared for a different case series, case scenarios, or health conditions that we perhaps have to handle. So in this background, the recent move by the Government of India Health Department to make a shift from illness to wellness. The wellness centers which have been launched by the Union Health Department, close to about 1.5 lakhs have been situated at different places all over the country, where while treatment of the disease itself is not the focus, although some first aid, of course, is available there, but most importantly, promoting wellness and, of course, continued care of many of the other conditions are the responsibilities which would happen at the wellness centers. So the very word wellness centers is a shift from what we may call as a clinic to hospital to just a health center, the primary health center, what we used to call it, and now the wellness center. So this wellness is well above that of normal health. That has to be promoted. So promotion of health is the ultimate. When health is promoted by whatever it be the means that we adopt to, health promotion would perhaps lead to reduction of disease burden. So with this concept, the health wellness centers have come up. So the movement from illness to wellness is something that we need to keep in mind. In this process, we have also realized that the non-communicable disorders have origin in the psychosomatic domain. In other words, a great deal of contribution from our psychological conditions have an impact on either the genesis of these conditions or its progression or worsening as well. While there are, of course, a host of other environmental lifestyle factors that operate, but the behavior of the lifestyle and the very emotional state that we reach out, both these things, the behavior is under our own control and the emotional state may be or may not be under our control at some points of time. These contribute substantially to the contribution and worsening of these non-communicable disorders, which we are now seeing as a national, perhaps silent epidemic. I keep hearing sometimes that we could soon become the world's capital for diabetes. We could well be very high in terms of suicide rates in the country. And mental disorders, we are no lesser than many of the other international countries, populations, where we also contribute to with the very huge number of our population. Mental disorders come into a very important size which we have to handle. So put together, this spectrum of psychosomatic conditions would be a focus of attention to general physicians, primary care doctors, psychiatrists, endocrinologists, and a host of other medical specialists who will have to be called upon to attend to this, including pediatricians for that matter. So we have a a wide spectrum of clinical clinicians who will be called upon to manage these conditions. So in this process, how does promoting wellness have an impact on this spectrum of psychosomatic conditions? I can illustrate by virtue of being a psychiatrist, I can illustrate some of the biological examples of how the mental state can have impact on the physical health. I'm sure many of us would have read it during our MBBS days. Older amongst us would have read it as psychosomatic disorders, and newer amongst us would be talking of stress-related mind-body diseases, metabolic syndromes, and so on and so forth. So a wide range of these conditions which have had a root in our mental state required to be managed by way of whatever we think is an evidence-based effective lifestyle intervention. In fact, lifestyle medicine has been a fad these days. Many centers running lifestyle medicine courses, diplomas, certificate courses, and some boards are also giving this recognition to these courses, if not in our country, elsewhere. And so the lifestyle medicine is something that has cropped up in the recent years. So also the mind-body medicine that has cropped up, and there are societies handling these two conditions, although they are not very much different on two different labels. People talk about how to impact health, promote wellness using approaches which are, as they claim, evidence-based approaches in lifestyle management, and of course in improving our psychological status. So having said this, let me illustrate how there is a biological evidence that stress has a place in causing or contributing to the non-communicable disorders, and how some interventions can actually not just reverse the psychological condition, but also in quotes correct the underlying pathophysiological status that has been caused either by the psychological situation or be the cause themselves for the psychological condition. I don't want to differentiate that issue. That is a different argument altogether. But what remains to be understood is a biological correction is also possible by some of the interventions. You have heard of many of the long-term studies which have talked about lifestyle intervention, improving coronary heart disease, preventing them, making their outcome better, talking about yoga in hypertension, meditation in hypertension has been discussed. And recently we saw a diabetes-free India, and we had a series of national level trials on yoga in diabetes, showing substantial benefit of practicing yoga in terms of improving diabetes, reversing diabetes. Just today, I had an opportunity to visit a friend for a lunch, and they were describing, family was describing to me, somebody who had a hepatic fatty liver was able to manage his diet and some discipline. The reversal of process is happening as demonstrated by some of the investigations. So much so, a very senior physician handling liver diseases was surprised as to how, without any treatment, this reversal has been made possible. And it was explained to him, apparently, by the person who was affected, that a lifestyle management discipline and keeping a diet which is totally different, which is tailored to improve this condition. So we have had interventions that are possible, made available in the public domain, in publications, evidences has been built. What I will probably share is something to do with depression, where again biological changes happen which are not healthy to one's, which are not good for one's health. Take, for example, depression. Depression is a condition which you will see very commonly. It is an ubiquitous condition, affects from children, adolescents, middle-aged people to older age people, although it is commoner in older people. And there are several other causes for depression. I'm not going into those things. But what typically happens in depression, depression is a form of a mental stress. Of course, mental stress also can cause depression by way of many societal changes, interpersonal stress, financial stresses, job stresses, education, and a host of those things can also contribute to depression. But depression itself is also a stress. Feeling continuously low, not being cheerful, not able to enjoy life, having a very low self-esteem, and not able to finish tasks because of this low self-esteem and slowness in the mind. All put together, the stress accumulates. And we know one of the common stress physiology is the release of cortisol. And this release of cortisol happens in depression and quite well demonstrated, and is also resistant to suppression by oral dexamethasone. In fact, oral dexamethasone suppression test was had almost become a diagnostic test, although the sensitivity and specificity continue to be discussed. What remains to be understood is the levels of cortisol increase and remain elevated for a long time in depressed individuals because it is a chronic stress. Unlike acute stress, where also, of course, cortisol levels can go, but it will soon return with the individual getting back to normal condition. But continued stress of a depressed individual for a long numbers of days elevates cortisol, and a cortisol has it starts a cascade of events. One of them is its effect on release of what we call as the brain-derived neurotropic factors. On one hand, second thing is directly affecting the glucocorticoid receptors, particularly in regions which are very sensitive to memory, hippocampus, and such areas, where by virtue of the glucocorticoid receptor agonist activity of this cortisol, there are some neuronal damage that also happens. Neuronal repair is prevented by way of the brain-derived neurotropic factor release being stopped or reduced or attenuated by way of increase of cortisol. And we know that in depressed individual, the repair mechanism suffers because of low levels of brain-derived neurotropic factor. Multiple studies have demonstrated low levels of brain-derived neurotropic factors in depression, which gets corrected after the depression gets better, if not totally, and that people who have a treated condition versus healthy subjects, the differences get very much narrow. We also found that this condition of low BDNF, increased cortisol, has another effect, as I said, the direct brain damage. And people have shown elsewhere that chronically depressed individuals have loss of gray matter, and which is typically what we keep hearing in our earlier subhashitas, Chita dahati nirjeevam, Chinta dahati jeevanam. So you're continuously stressed. These cycle of events contribute to your own loss of some very important critical neuronal cells, the gray matter, and in turn you go on to become diseased with respect to brain. Your memory functions come down, and with chronically depressed individual, one could even end up with significant cognitive dysfunction as well. So this cycle of events have to be reversed. We, of course, treat depression. As I said, the treatment of depression, cortisol drops in some people, if not consistently demonstrated. The brain-derived neurotropic factor increases. Have people shown whether there is also recovery in terms of gray matter loss? I'm not aware of such studies yet. So antidepressant drugs work. we also had an opportunity to offer people yoga as a treatment for depression. Very interestingly, yoga also produced reductions in depressive symptoms leading to remission. At the same time, the blood levels of cortisol also came down in depression, and corresponding increases in brain-derived neurotropic factor also happened. In fact, there was a good association in those people who lost cortisol. The brain-derived neurotropic factor levels was actually higher at the end of a 4-week intervention with yoga alone in depressed individuals, and they remitted as well. Although I wouldn't say it is a demonstration in a randomized clinical trial as one may seek at this point of time, there is a effect of this. We also were able to demonstrate yoga practices prevent age-related loss of gray matter, particularly in the hippocampus. So one of the intervention, which is a lifestyle intervention, yoga, which in the studies which I mentioned, used the yogasana and the pranayama, was able to demonstrate not just the clinical reductions in the stress level, one of them demonstrated by reduction in the depression scores, but also a biological correction with respect to reduction in cortisol, increase in the brain-derived neurotropic factor, and in other individuals, of elderly individuals, improving the gray matter loss. In other words, attenuating the gray matter loss, but also perhaps increasing the size of the hippocampus. So there have been studies which have accumulated over this period demonstrating the effects of yoga on several other biological parameters which are conducive to health in this spectrum of conditions which I talked about. Some of the examples include it improves the GABAergic transmission in the brain. It increases the heart rate variability. All these things have a contribution to different systems of our body, which will promote healthy or promote wellness. So given this scenario, one of the lifestyle introductions in mind-body medicine could be yoga. Not just yogasana and pranayama as the studies I mentioned, there could well be the yoga lifestyle which includes the yama and the niyama, the don'ts in our life and the do's in our life. If we can put these things together and add it and blend it with the Ayurvedic concepts of our diet, which is related to different seasons in the year, and not just different seasons in a year, depending upon one's nature, which is called as the prakriti. With that, if you can blend you can create a cocktail of lifestyle which has yoga, perhaps in addition some more of dhyana, not just yogasana and pranayama, and a yogic other behavioral lifestyle which includes the yama and niyama, and together with the physical lifestyle which is recommended in the traditional Ayurvedic literature of the food in sync with the nature outside and the nature inside, you will perhaps achieve a more holistic transformation of a lifestyle which would contribute to promoting wellness, and this could well have had an impact on these spectrum of non-communicable disorders. Research is going on. We have to build evidence. We have to build evidence for a long-term cohort studies as well, which at this point of time are lacking. And here we are in this symposium. There could well be many younger faculty, younger postgraduate students, much younger doctors who could perhaps take this initiative and take it forward in your workplace and be able to develop and synthesize this idea into a long-term research design. In fact, from the National Medical Commission, as you may have seen, one of the regulations of the internship, we have facilitated one of the Ayush subjects that could also be taken up by MBBS students during the internship as an elective subject. Which means we are legitimizing some exposure during our formal internship period to these interventions that could well be from the Ayush, either yoga or Ayurveda or whatever that is available in that given hospital, given institution, given medical college. So with this change that is happening, and with the Yoga Day having made yoga far more acceptable than what it was, the mind-body medicine and the traditional interventions of yoga and Ayurveda cannot be separated, and it has to be blended. And these conditions, these interventions, which may not involve medicine or what we may call as herbal products, which they have to take it for disease. Without these things, making a change in lifestyle, it is possible with one's own self-control and one's own getting empowered into practicing this. So the community at large is going to benefit from improving their wellness and in turn a better mind-body harmony, and so fewer mind-body disorders. And one of the preventive strategies in the mind-body medicine is achievable using these traditional interventions. So I wish all the participants good luck. I wish also the organizers all success in this symposium. And once again, let me thank each one of the organizers for inviting me to participate in this 4th symposium on mind-body medicine. Thank you very much and wish you all the best.
Thank you, sir. Causing changes in neurohumoral response, raising cortisol and reducing BDNF, and that's how causing the mental illnesses. Thank you very much for that. After this, I hand over the mic to Dr. Vaishali.
Thank you, Dr. Marwai sir, and thank you, Dr. Gangadhar sir, for always being a guiding mentor for us. And we could come to this stage with his guidance and with his help. And I'm sure that we have still many more things to learn. Now we come to the V.A. Lokhandwala oration. Dr. V.A. Lokhandwala sir has been my medicine guide. And he's been my teacher, and he is one of the reasons why I am into mind-body medicine. So I welcome you all to this oration.
Good afternoon, everyone, and welcome to our second session for Hall B today. The topic for this session is all that aches and pains. And for this topic, I would like to introduce our moderator, Professor Dr. Shetkar sir. Dr. Shetkar sir is a senior consulting physician and professor emeritus at Srimati Kashibai Navle Medical College, Pune, and the ex-professor of medicine at KMC Hubli and PIMS Loni, and has been a clinic practitioner for the past 25 years. Dr. Shetkar sir has an enhanced quality in good medical practice and holistic medicine, and he will be the moderator for this session today. Over to you, Dr. Shetkar sir.
Thank you, Pauline Madam. At the outset, I thank Tony. At the outset, I thank the President and the Secretary of the SPEAR, Dr. Chetan Deshmukh and Dr. Vaishali Deshmukh. The SPEAR, as already you know, that it is Society for Prevention, Healthcare, Education and Research. This is the unique trust, which is a charitable trust, non-profit organization helping for the medical education, and it is the fourth conference, international conference they are conducting. It's very unique in its character. Very much thankful to the both President and the Secretary of the SPEAR. So as Paulmi has already told that these are four persons are talking today. The first speaker will be that we have got two rheumatologists and one psychiatrist and one physiotherapist. They will be discussing. The first speaker will be Dr. Chandrasekhar. He is the medical director. He is the MD, DNB and DM in rheumatology and immunology. He is a medical director at Chandray Rheumatology and Immunology Center at Research Center at Bangalore. And presently, he is the president-elect of the Indian Rheumatological Association. He is the winner of the youngest scientist, that is Sir C.V. Raman State Award for Scientist from the Karnataka State Government. And he has deliberated so many orations, especially we are lucky that even your IMA of the Pune also has delivered oration in 2019. And he has also delivered oration at Karnataka chapter of API and also at Indian Rheumatological Association. Today he will be talking on mindfulness on management of pain and inflammation. I request Dr. Chandrasekhar to enlighten us.
Greetings from Bangalore. I am Dr. Chandrasekhar S. I thank the organizers for inviting me to be a part of this wonderful initiative, especially about the mind, body, and the disease. I will be speaking about in the next 15 to 20 minutes about the mindfulness management of pain and a little bit about the inflammation. So the major confusion or issue comes to us is what is the mindfulness? How does mind influences the pain? Is it really a right way to handle the pain? Which are the pain where we should use these techniques, and how and where and when these techniques should be used? To get into the real scientific crux of the pain and mind relationship, I would like to sensitize the audience about the pain pathways and what are the possibilities of interventions, how as a medical practitioner or medical field works with. As all of us know, there will be a stimulus. The stimulus is perceived by the peripheral nociceptors, which in turn moves into the spinal cord. After passing through the gate pathways, subsequently it moves into the thalamus. From thalamus, they are radiated into or moved into the higher centers. So there are 3-4 levels at which the pain gets altered, augmented, or changed. So one of the place where it is the quantum of injury or insult at this site, which is triggered or managed or caused by the histamine release, substance P, and inflammatory mediators, which in turn stimulates the nociceptors, which makes its way through the spinal cord, where there is a gate pathway, the gate pathways which can alter or augment or accentuate based on the scenarios in the spine, and through the ascending pathways, through thalamus, it gets relayed into the brain. That's where consciously we start perceiving about the presence or absence of the pain. So we use different interventions. If there is anti-inflammations, we use anti-inflammatory. If it is edema due to histamine, we use antihistaminics. And sometimes even the opioids and opioid receptors also influences the peripheral nociceptors. Transmissions can be blocked by the root ganglions. Some of the alpha-2 antagonists, MDA receptor antagonists, modulates the perception or the sensory transmissions into the brain. And some of the general anesthesias and few of these other alterations can alter the way the brain perceives the pain. So having said that, now the question is, what are the things which determines the intensity of pain? When an individual feels that it is agonizing, pain in the scale of 10 compared to in the scale of 4 or scale of 0. See, one of the major problem when it comes to the research of pain is how to assess the pain, how best we can assess the pain. There are several determinants of the which decides about the intensity of pain. Number one is the triggering factor from bottom up, and next is the intactness of the pathway, and next subsequently the perception of the pain by the mind or by the conscious mind. So the trigger factor, as I said, it could be the amount of wound, amount of injury, a scratch or a quantum of inflammation, number of joints involved, the organ spasms, etc. The intactness of the pathway is not intact. Suppose in the diabetic neuropathy or a peripheral neuropathy, so the pathway itself is not intact, so pain may not be perceived despite of a very ugly looking wound. And then is how the brain perceives or takes it as a real cause of concern or not a real cause of concern. So this is where the mind game starts, where how a pain is perceived or how well or how much it is taken into a consideration. So as I said, when it comes to autoimmune rheumatic disease, that's a forte where I'm going, where I have worked from last 20-25 years. One of the major cause for pain is inflammation. And other possibility is a structural damage, either caused by inflammation or directly with the aging process, as happens in osteoporosis, or there could be no inflammation or no structural changes, as it happens in fibromyalgia and few of the chronic pain conditions which we use. So if it inflammation, the pain comes down by resolution of the inflammation or by blocking the inflammation. Structural damages can be modified or improved by using surgical corrections or splint and support. When there is no inflammation nor structural changes, if you have an isolated facial pain or some sort of pain, you can use blocks and few other techniques of stimulations and counter stimulations. Or the next possibility is to alter the perception. So how best the body perceives the pain, and that if you can alter, you can work on the pain. So that's where the mindfulness, yoga, and most of the other alternative modalities where you can alter the way individual perceives the pain can be utilized. So the other concept I would like to introduce is something what we call as pressure pain threshold. The pressure pain threshold is a sort of measure how best one can measure the pain. So this is used often in the pain research as well as in biofeedbacks and other areas. This is one of the objective way to measure the pain. So usually we use the pressure algometers, wherein you can apply a pressure on a specific point, the predetermined point like in scapula or the prominence of the ulna or prominence of the styloid process. When you are applying the pressure, there's a point where the person indicates that he is feeling pain. And that's a point, and that's a pressure point where we call it as pressure pain threshold. That's the point where the amount of pressure that is applied on an individual becomes painful. Is PPT is universal or uniform across the population? Answer to that question is no. Pressure pain threshold varies from individual to individual, in a single individual from time to time, and also depending on both physiological and pathological conditions. So that being the case, what are all the indicators? What are the prominent things which decide or which determines the pressure pain threshold? For example, the scapular position has the lowest pain threshold. The minimal pain, even a minimum pressure, can produce a high perceptions of pain. There is an influence of gender. Females are having a low pain threshold. They're very sensitive to pain compared to the men. And of course, the age influence on the pain threshold is not very significant, but of course we see a sort of a bimodal distribution. Sometimes the pain threshold is very low in the children and gradually it rises as they become teenagers and may come down again once they are youth and struggling with their life, and may start increasing as the age increases. So it has a bimodal distributions and varies from age to age, but it has a very weak influence because we have a very several distribution, a distribution of these pain threshold across the same age in the different levels. And again, whether obese has a different pain threshold, most of the studies have not shown a significant influence. Does alcohol influence pain threshold? Answer to that question in the recently published systematic survey was no. And there is some entity what's called as pain vigilance. Pain vigilance. It's a sort of a personality where even a little pain is given a due consideration. I mean, depends from individuals. Anybody who has practiced medicine would have known that some patients keep on telling even a minor change in the pain in his each visit. There are some patients who says that, oh, it's okay, doc, I think there was very little pain here and there. I mean, it didn't really disturb my things. Whether that pain vigilantism, that sort of a giving importance to every pain, does it change the pain threshold? Answer to that question was from the available systematic surveys was also no. So the pain threshold to certain extent is independent of the influence of the mind, and also the studies which also says that the depression doesn't much influence the pain threshold. The menopause also may not much influence the pain threshold, but there are certain factors which can alter or augment the pain threshold. We did a research in 2012 and 2013 and 14. At that time, we were keenly working on pressure pain threshold, whether this can be used as an instrument for differentiating the patients with fibromyalgia and rheumatoid arthritis. And also in rheumatoid arthritis, can it be one of the guideline for looking at the difference between the improvement in the inflammation? Certainly, there was a significant change as there was a change in the DAS-ESR. As the DAS-ESR came down, so also the average pain threshold, the average bearing pain threshold capacity went on increasing. So there was a significant improvement in the pain threshold from the lower to higher pain threshold. So also if you could see, based on the change in the DAS, that as the DAS change was more towards improvement, that is, as there is a reduction in DAS, the pain threshold also dropped. So also as there is an increase in the pain threshold, the DAS-ESR, the pain threshold was moving on the upper side. So suggesting that the rheumatoid arthritis activity DAS score was influencing the pain pressure threshold. But when we try to correlate or match with the inflammatory parameters like CRP and ESR, they were not significantly matching to each other. This variation, as we could understand when we worked it further, was because this was because of the variation which was inter-individual. The inter-individual variation was so much, the number of subjects who were required for our study was very high. Probably that was one of the reasons why we really couldn't see the correlation between the inflammatory parameters as well as the pressure pain threshold. Definitely, with the increase in inflammation, the pressure pain threshold, the pain threshold drops. The individual's perceptions for pain varies. But there is very one interesting observation. Of course, I couldn't show you those slides and those things. When we assessed visual analog scale and the pressure pain threshold and its relationship to the changes within the pressure pain threshold, in the patients with fibromyalgia, what we could see was there was a significant discrepancy between the pressure pain threshold change as well as the changes in visual analog scale. Because visual analog scale of a pain as is what patient perceives as a pain. Because visual analog scale, we ask the patient to map or to indicate how much of pain he has felt, and based on that, it's going to be mapped. So that's how visual analog scale was not matching to pain pressure threshold. So that means in a scenario like fibromyalgia or conditions where there is no inflammation or anything, probably the mind and the perception is going to influence the way we look at the pain. So the implication of these discussion above is pain is a sensation. The threshold vary depending on the intensity of the causative factor. Pain is a perception which is entirely handled by the mind and consciousness. So pain is a perception, varies in its intensity from time to time and also from person to person based on the status of the mind. So whether he is ignoring, then the pain may not be perceived so much. If he is happy with it, the pain may be perceived as a pain, because some of the painful things are also considered as a pleasure. So the pain is also sometimes taken as a pleasure. So all pain is not necessarily to be perceived as a distress. So pain could also be the other way around, a pleasuring sensation. So that's how pain as a perception varies, pain as a sensation varies. So that's how the management of the pain has the mindfulness, altering the minds and minds perceptions do influence how one can manage the pain. So the mind has a strong influence on pain and also vice versa. So the pain also has a stronger influence on the mind. So what's the literature says about this mind and pain control? I mean, the recent thing is to search in the ChatGPT. I just gave a simple search, mind controls pain. And what was interesting answer from the ChatGPT was, yes, it is possible to control pain through the power of mind. And you could see the effective way in managing the pain is the mindfulness meditation. That's the crux of topic, what I was trying to impress upon. The mindfulness meditation and counseling, the other one called CBT, cognitive behavioral therapy, can change and help with reference to the pain. So pain can be altered or augmented by altering the mindfulness as well as improving the perceptions by other techniques like CBTs. What about in the scientific literature? If you look at the PubMed has more than 1,500 articles. You could see the off late, the number of literature which are published with reference to mindfulness are gradually increasing. So what it means to us is we discovered a lot of NSAIDs and anti-analgesic drugs in the past 10 decades. And now we have enough of those available chemicals, but it's not just that which are going to influence the outcome. The outcome is also going to be influenced by mindfulness. You could see how the literature search is, how the search is going on, research is going on with reference to mindfulness and meditations. So is it evolutionary wise, is it true? Is it something which really happens? Yes, the answer to that question is evolutionary biology also says the same, because we need to remember all of us are evolved out of a human being who was earlier hunted by any other predators. So body has developed to work with the predators. So any stress, whether it is psychological, mental, exam taking or anything, the stress behavior of the human has developed from the predator's stressors. When there is a predator stressor, what is required is a full attention and the entire sensory system, it should be in its fullest capacity to fight or get the sense out of the surrounding environment. So that being the case, what happens when you are distressed? As a reaction, you have a stress hormones released, both adrenaline as well as corticosteroids. What do? They reduce the threshold for all sensory stimuli, including the pain. even the visual sensories becomes high, the auditory sensations become high. So also the perception of both pain and touch becomes high. And also attention and perceptions to the sensory system becomes high. So as a result of which, when your mind is distressed or in a high alert or a high stressful state, the possibility of pain threshold being low is very high. It's basically because stressor hormones which are released is going to keep the pain thresholds high. So also the perceptions high, which is the other way around when you have a stable mind and a calm mind. So your sensory threshold is low, is very high. So your feeling for the pain is less. Attention and perception is also low. These are the one which we can alter or modify by using mindfulness or mindful techniques, yoga, and other meditational processes. So having said that, I'm very clear that one can utilize the mindfulness meditations. We need to remember, we need to mind using these techniques. Fundamental principle of medical practice is no harm. So advise the best way to grow over the pain. So what I mean by this is, where there is no harmful pathology, or it has been eliminated or managed, and that's a place where one can use, still the patient is continuing to suffer from pain, that's a place where you can use mindfulness and meditations or alternative or a complementary suggestions. For example, if patient has an active rheumatoid arthritis, active ankylosing spondylitis, or an active reasons for a pathological reason for his pain, it's not the mindfulness what is required. It is to attend to the pathology which is responsible. Unless you bring down or control the inflammation of rheumatoid arthritis, you can use simultaneously mindfulness or any other meditations to bring in or alter his perception on the pain. But at the same time, it becomes necessity to avoid the harmful pathological process, which otherwise could cause damages. So where pathology is causing pain, which are less likely to resolve or may need little prolonged time, or not sure what the pathology is, but nevertheless not harmful. So that's a place one can use the mindfulness and all this complementary system, which is really useful, which can bring down the use of NSAIDs and opiates. So here comes a next practical principle. If you can't get rid of the distress, learn to endure it. The pain as a distress, if you are not able to eliminate by any of the mechanisms that what you think is any pathological process, when you're unsure about it, probably using these mindfulness and those techniques, what we otherwise classify or categorize as chronic pain, will be helped out. So again, if there is inflammation, try to resolve or block it using the medications. If there is a structural damage, correct with surgical correction, splint and support. If there is no inflammation nor structural damage, you can try blocks but may not be useful, and you can use other techniques or go with altering perceptions. That's where mindfulness really works in autoimmune rheumatic diseases or in any of the painful conditions of a chronic origin. I think I am left with another couple of minutes. I'm expected to touch on inflammation and just a quick glimpse of how inflammation is influenced by mind. I mean, as I said, most of us are multicellular, humans are multicellular, multisystem organism. Homeostasis is the key to the normal health. Any stress can lead on to the inflammation. As I said, from the evolutionary biology, body prepares for an injury as a predator stress. So even whether it is physical, mental combinations or any of them, usually it is responded by inflammation. The same cytokines are secreted and same stress hormones are secreted. So as a result of which, though the cell affected could be 1%, but the reaction is reflected into the several cells. And this is where the super system interacts to maintain a homeostasis, which include neurological system, the mind and brain, endocrine system and immune system. They cross-talk each other to bring in the homeostasis. Inflammation is one of the process which is influenced both by neurological and endocrinal system. The mindfulness or altering the neurological component on the inflammation can alter or augment or attenuate, whichever, depending on the situation to situation, to help or cross over the role of inflammation in the disease management. So they need for reactions of defense, healing and repair, coping and attaining homeostasis. To share the burden, inflammation is necessary. Altering it and keeping it in the best shape is something what is essential. Study about whether the mind has an influence on the inflammation, but our study with reference to yoga and rheumatoid arthritis indicated that the yoga practicing or mindfulness or any of the meditation technique, including pranayama, didn't much alter inflammatory parameters, but certainly influenced the quality of life, disease activity score, etc. So that suggesting that when there is a pathological process, probably just altering mindfulness or meditation may not impact the inflammation, but certainly makes the individual to endure those inflammation with reference to the quality of life. Say simultaneously, as I said, you need to intervene with reference to managing the inflammation and also take care of the pain. So use of mindfulness in managing inflammation needs extensive study. Probably it may help or alter or reduce the amount of NSAIDs or immunomodulators which are required, but it needs an extensive work. Maybe down the lane, after 2-3 years, when I speak back, probably we may have a little more experience in how using this, how much it alters with reference to this. Thank you very much for giving me this opportunity, and the things are open for questions. Thank you. Greetings from Bangalore. I am Dr. Chandrasekhar.
In addition, you have given the importance of the mind and pain control, how they interact each together and help in allaying the pain. I request the delegates to keep the questions in chat box. At the end of the session, 10 minutes, we'll have the discussion on the questions. Now I request the second speaker. Second speaker is Dr. Vijayatalago Joshi Madam. She is one of the renowned rheumatologist of the Pune. She is working in the Dinanath Mangeshkar Hospital. She is actively involved in the research on the rheumatology. She will be speaking on the knee and back pain in diabetes. This is the commonest problem which we face day and today in diabetic patients, especially about the back pain. I request Madam to deliberate on the knee and back pain in diabetes. we'll proceed to the next speaker. Please put the slide of next speaker. Next. Next speaker is Dr. Geeta Desai, MD, DNB, PhD, and she is a professor of psychiatry in the prestigious Nimans, Bangalore. She has several publications at both international as well as national journals. Her research project is more on chronic pain and somatoform disorders. So we are lucky that our topic also given to her is chronic pain in diabetes. We hope she will justify us and enlighten, because she is basic research worker in the chronic pain. Over to Madam.
Thank you, sir. And shall I share the screen?
Yes,
Yes.
Yeah, okay.
ma'am, sure. We'll have the team just get off this slide and then we'll.
Yeah. The slides are visible?
Yes, ma'am.
Okay, I think I shall. All right. Good evening, and first, my thanks to Dr. Vaishali. She's been extremely, it's been a pleasant interaction with you, Dr. Vaishali, and thanks for asking me to do this presentation. For me, I think this whole, I have gone through the Synapse brochure multiple times, because according to me, probably pain is one condition where it exemplifies what mind-body medicine is. I don't think any other symptom or diagnosis exemplifies this. And thanks for including pain in this whole discussion. So let me begin with, I'm a psychiatrist, so I see probably different, I have a different aspect on how I look at pain. So let me begin with a question. So when does a psychiatrist, see patients? When do we get referrals? I think the first and foremost is when most of the investigations are done and then there is no evident cause. That is the one time we get referrals. Or when the physician feels that the pain doesn't really correlate, the way the pain is experienced doesn't really correlate with underlying illness, or when they suspect a comorbid psychiatric illness. Sometimes we do get referrals in the institute where we work is when they are going to do an intervention for chronic pain and they want us to do an assessment. I'll tell you why this is important. And when patients are expressing suicidal ideas related to pain. And when pain interventions does not relieve pain. Like, for example, I know that many of them have had neuropathic pain for years together. Multiple interventions have been done, and then, pain doesn't go away. Or there is a comorbid substance use. These are the common reasons why a person is likely to be referred to a psychiatrist. Now, I think what I'm going to focus is predominantly on chronic pain. And acute pain, we know that, it has some adaptive role. There's a clear etiology, and you treat the cause and it leads to improvement in pain. Whereas chronic pain, I think, is beyond the expected time of healing, has no adaptive role. So either, even if there is a clear-cut cause, there can be, factors that are probably exceeding the expression of pain in these patients. Now, why are chronic pain patients, any different from any other medically unwell patients? So I think one of the common reason why chronic pain gets discussed in psychiatry as well is, I think there are very high rates of psychiatric illnesses, psychiatric conditions that are seen in patients with chronic pain, very common comorbidities, because we also see patients who have had mental illness or, let's say, depression and anxiety also to have high rates of chronic pain, vice versa. People who have had chronic pain for a long time also experience anxiety and depression. I think having a psychiatric illness modify the risk of developing chronic pain. And probably, I think what I mentioned, somatoform disorders, that is one condition which is a psychiatric disorder where pain can be a very prominent symptom. Now, coming to what are the common comorbidities that we see in chronic pain? First one is major depression, then anxiety disorders, somatoform disorders, substance abuse. Now, that does not mean that persons with chronic pain do not have other conditions. There can be other conditions as well. Now, I'm only talking about disorders. There are a lot of psychological constructs that can happen in patients with chronic pain. Like, for example, pain catastrophizing or affective distress associated with chronic pain, illness behavior, abnormal illness behavior, or it can be, health anxiety, which can be there, constant or health related worries. So demoralization. So many of these things can coexist as a part of chronic pain, and they may not meet diagnostic criteria for psychiatric conditions. But I think it is very important for us to be aware of this, because many a times we may not see a major psychiatric disorder, but we see a lot of this. Like, for example, someone with pain catastrophizing might avoid any kind of physical activity. So when we refer them to yoga, or we refer them to, physical therapies, they are very scared of doing any activity. So what they do is avoidance, and avoidance, as we know, it actually worsens the pain course. So handling these thoughts related to pain, what I said, pain catastrophe, that means they feel that any activity is likely to worsen their pain. It is an important construct that we also need to be aware of. So coming to one of the most common comorbidity is depression. And there is a bidirectional relationship. There's a lot of literature which says that, depression is one of the commonest comorbid condition in chronic pain. Now, each one influences the other. There are a lot of commonalities. There are common shared etiology between depression and chronic pain. Like, for example, a person who has had adverse childhood experiences, it can be severe physical abuse or neglect or any of these. They are both at risk for developing depression as well as chronic pain. And depression and chronic pain together, actually the morbidity is quite high, and it can lead to poor, significant dysfunction, as well as it's considered to be a poor prognosis. Now, we know that a person who's in pain can also experience a lot of emotional disturbances. How does one diagnose depression in a person who's been going through chronic pain conditions? This is the commonest question. Like, many of the features, like, for example, a person with chronic pain may have sleep disturbances, may have, fatigue, difficulties in concentrations, which can also happen in, occur in depression. I think what we are looking at is, when someone is depressed, there's a pervasive, persistent, low mood, sadness that they experience over a period of time, like more than 2 weeks or even 4 weeks. Along with, they have a lot of negative thoughts about their condition, negative thoughts about themselves, or feeling hopeless about treatment, helpless, worthlessness. So these are the thoughts that are there. And they can have low self-esteem or pessimistic views. But many of these symptoms need to be present to actually diagnose depression in persons with chronic pain. And sometimes it can pre-exist, both can start together, or one can come off one after another. So I think one of the questions that we keep asking them, many patients, when they come, they do not want to discuss about their emotions, or they say that it is, I am depressed because I experience pain. So I think it's very important for us to ask the right questions to diagnose depression. So I think we all know that many of the antidepressants have analgesic properties. Like, for example, we know that amitriptyline for even 10 to 25 mg, it's a very commonly used drug for in the treatment of neuropathic pain, and many SNRIs are being duloxetine. They all have also properties of for depression. But the dosages that we use for treatment of depression is quite different from the dosage we use for pain treatment. Like, there are many ways they can improve, they work as analgesics by all these mechanisms. One is they may improve sleep, they can improve, reduce depression, they enhance endogenous opioid functioning, and as well as immune regulation. There have been very interesting studies on neurobiological, underpinnings of both chronic pain and depression. And what they found was the immune system disturbances are similar to what happens in chronic pain as well as in depression. Even the cognitive deficits are also the same. So the other conditions that anxiety disorders, one I mentioned is about health anxiety. Some of them who've had very severe pain experiences also tend to anticipate that pain experiences and then develop significant panic attacks, or they could have worry a lot about their pain. Why is my pain not going away? Constantly, their mind is, getting a lot of thoughts related to pain, and it's as if the worries take precedence over everything else that they are thinking about. It's like they wake up with pain and then they think about pain. What is it that I can do? How do I get rid of it? And why is it not going away? So it kind of becomes like a rumination. They constantly worry about. And it may not just that. Once somebody is suffering from chronic pain for a long period of time, it starts affecting their daily routine. It starts affecting their work, relationships, families. So the worries just add on, pile up on one another. So anxiety is something that is not commonly discussed, but it is a common condition. And I think some discussion with the person is, we need to ask questions. Have they been worried? And what is a normal worry and what is an abnormal worry? Something like I was saying, that if it is there for a long period of time, they are not able to relax and they constantly feel on edge. So these are some of the symptoms of anxiety that are seen and pain catastrophizing, which I mentioned. Now, as the severity of pain increases, multiple sites of pain, they can have influence on the severity of depression as well as severity of anxiety. And comorbid substance use, like for example, I think whenever we discuss pain, the only substance we talk about is opioids. But of late, what we've also seen is many of them use, alcohol has always been there. As we did a study and looking at chronic pain in patients who have been diagnosed to have alcohol dependent syndrome, about 18 to 20% of them did experience chronic pain. And most of them were elderly, and they used alcohol as a method to cope with the pain. At the same time, I think pain became a maintaining factor for treatment for use of alcohol. So I think in our condition, it's also important to talk about nicotine as well as cannabis. These are some of the common drugs that have been used, apart from opioids that, people do use, over-the-counter medication. Sometimes I think over-the-counter medication need not be an opioid. Even non-opioid medications, like, for example, we've had patients who use even it can be simple paracetamol, but they use 5 to 10 tablets of paracetamol, because they're so worried that the pain will come back. So I might as well take a medication before the pain comes. So other substance use disorders, I think that's a common condition. We need to probably be little more cautious about on how we assess, how we ask questions, as well as how to get, how to monitor when you prescribe opioids for pain conditions. Because now earlier opioids were being used, specifically used for cancer pain, but now I think opioids are being used for non-malignant conditions as well. So is there any way, can physicians be a little more alert in, assessing who can, where we need a more stringent monitoring, who is at risk for developing, misusing opioids? So we all know what is happening in US regarding opioid crisis. So I think it's very important we have, like, for example, somebody says that they've had euphoria with or felt happy or mood elevated with opioids, then you need to be a little careful. If they've had any past history of addiction, and if you feel that this person is more likely to, is at risk for misusing the substances. So like I was mentioning, I think there are other substances which we don't pay attention to, because some of these substances are probably culturally accepted, and I think now cannabidiol oil, we've known many clients who've actually this is being promoted in chronic pain conditions. So it's a very ethical dilemma, because when someone is, using these substances to relieve pain, or whether we are not able to provide pain, how do we, kind of balance it out? So I think, but it is very important to be aware of when to screen, and at what points of time you have to screen, and how to address when somebody has these substances. Other thing that I just wanted to highlight is, many a times I think suicidality is discussed in the context of depression, but there's enough literatures to say pain is an independent risk factor for suicidal ideation. So it's very important to ask questions related to suicide, especially somebody who's been having chronic pain, which is a non-remitting, severe. So it's okay to ask questions about suicidality, because there is also a fear in us that whether, asking about suicidality, are we giving them ideas? So it's not true, and we need to ask them about suicidality. And many patients would like to talk about something very personal, and nobody would have asked them. So it's very important you ask questions, what kind of thoughts have been going through their mind related to about their life, and have they had any wish that it's better off dead than being, going through this suffering. I know that we all, I was talking about depression and anxiety. All these actually elevate the risk of suicidality. So it's very important, whether anxiety, depression is there or not, but you still have to discuss about suicidal ideation. So many of the phenomena that I was mentioning, if somebody feels very hopeless about their condition, and then they feel very demoralized. So these are patients where I think you need to really pay a little more attention and see that, we do assess their safety. Because many of them have medication, they can use different methods. They have, overdose. Most common is the overdose with pain medication. So I think one has to be aware of this condition as well, suicidality. We actually recently finished a study. We're looking at patients who have had pain for a very long time and what happens to their cognition. And interesting findings is, there was a very interesting article which actually discussed about how chronic pain is like a neurodegenerative condition. So over a period of time, many patients do develop cognitive deficits in the form of, most often it is attention and executive function deficits. Now, this is an important finding, and which is probably similar to what happens in depression as well. So now when somebody has depression and chronic pain, so cognitive deficits are likely to be present. So some of the conditions that have been reported, what we found was attention and processing speed, working memory. So more of in the prefrontal functions. Now, when somebody has difficulty in shifting attention, their focus might likely to stay in, what they're thinking, like they get stuck. Pain becomes their predominant preoccupation. So I think, of course, we haven't really, there are no studies which have looked at whether addressing or treating cognitive, functions. But I think it is one of the things I think Dr. Chandrasekhar mentioned is about mindfulness. So where you actually enhancing the ability to focus on a particular task. So mindfulness is one way where probably by improving the cognitive functions as well, it can improve pain perception. So there are various conditions where, domain-specific cognitive dysfunction has been reported. Now, so I have spoken about what happens to patients who have had chronic pain. What happens to patients who have had psychiatric disorders? I think one of the things that I mentioned, especially women who are more prone for anxiety and depression, they have reduced threshold for pain perception. And it is known people who are depressed and anxious, they have low threshold for pain perceptions. They have poor treatment response. Like I mentioned, it's poor quality of life, poor eval. And other challenges when somebody is, I was just curious to know how people respond, how physicians respond. And there is very interesting research on how does the gender of the physician and gender of the patient matter when somebody comes with pain, and which doesn't seem to have obvious cause. And many persons with mental illness also, even if they have pain, unlikely to receive proper evaluation of pain. And there's a lot of interesting research on pain sensitivity in schizophrenia, where there is an altered pain threshold and pain tolerance. So I think even persons with psychiatric disorders, both major and common mental disorders, definitely the pain symptoms are present, and I think we need to address it. We need to, probably as psychiatrists, we also need to screen our patients for presence of any pain conditions. So what I wanted to also highlight is in psychiatry, there are two conditions, like for somatic symptom disorders in DSM and ICD-11, bodily distress disorders. So these are two conditions where pain can be present for a long period of time and where there is no evident cause, or even if the evident cause is there, but they can still have a psychological component to it. Now, there are some discussions on how, these actually, the latest classification of ICD-11, there are some similarities. So should it be an independent diagnosis or should it be under psychiatric condition? So like I was mentioning, I think pain is one condition where mind-body medicine is probably the best approach, especially in chronic pain conditions where, rehabilitation seems to be the main goal. I mentioned about cognitions and emotions and how they influence pain perceptions, how they become maintaining factors in chronic pain, and how comprehensive assessment is very important. And who should do it and when should it be done? Should we be asking all patients who have developed chronic pain about psychiatric conditions? I would say yes, especially in patients who've been suffering for a very long time. The reason is if we use a biopsychosocial model, we are more likely to probably prevent some of the chronifications, as well as reduce some morbidities. So I think in that sense, it's very important that we do a comprehensive assessment of psychiatric conditions in the unpsychological construct. So I always think that it's early recognition probably will improve outcomes. And I think anyone can do a psychiatric assessment. It doesn't need to be always a psychiatrist. Any person who's treating pain, because depression and anxiety is easier to assess and can be treated at the physician level itself. And other important area that I think we have not researched is how communication happens regarding pain between physicians and the patients, especially when the cause is not very clear. And, when discussing about psychological variables, because many a times I think patients feel invalidated when it is said that, there's more psychological reasons for your pain. So I think it's very important how we communicate, how we give a mind-body approach in understanding pain is very, very important. And with this, I conclude. Thank you for this opportunity.
Thank you, Geeta Desai, madam. We are very thankful to you. You elaborated in detail about the psychiatric aspect and its conditions affecting the pain and pain threshold. In addition, we are unaware that the severe pain itself could be one of the risk factors for the suicide. We heard in the newspapers, we have seen some of the incidences where the people have committed suicide for the pain. But anyhow, you elaborated in detail. In addition, you have told very important to us, which were hitherto unknown, about the comorbid substance abuse, especially the cannabis, alcohol, and nicotine. Thank you, madam. Now I request Dr. Vaijayanti Lagu Joshi to start her presentation.
Right.
I believe it is now improved. Things have improved now.
Yeah, yeah. Yes, sir. Yes, sir. Am I audible, sir?
Yes,
Am I
ma'am.
audible, sir?
Yes, ma'am.
Yeah, and my slides are also visible.
Yes,
Thank you. Thank you, Dr. Shetkar at the outset, and thank you, Dr. Vaishali, for giving this great opportunity, again, interacting in Synapse, a great forum with all stalwarts. We have listened to a great immunologist, Dr. Chandrasekhara. We have listened to a psychiatrist review on this pain modality. And now I'll be putting my perspective from a clinician and a rheumatologist angle on knee pain and back pain. As we know, knee is a very dynamic, large, weight-bearing synovial joint of our body. The prevalence of knee pain in the population is reported approximately 19%, and this incidence goes on increasing steadily with the age. We come across the knee pain right from the juvenile age group up to the elderly senior citizen group, and this etiological spectrum goes right from injury, inflammation to degeneration. Knee osteoarthritis is a major cause of disability in the elderly, and the global prevalence is reported to be almost 16%. Back pain is another very common symptom, which is seen worldwide in all age groups, and it is a complex myriad presentation with myriad causes. 80% of the, they say, general population will experience back pain once in a lifetime at least, and the mean point prevalence has been reported to be around 12% in the general adult population. It is supposed to be the number one cause for the disability and the sick leaves globally. This is what is a normal knee joint and a vertebral column looks like. And nowadays, joint is also treated as a full-fledged organ with its unique structure and the functioning capacities. The joint is where the two or more than two bones meet. And these bones are supported by a number of other structures like the muscles, the tendons, the ligaments, the cartilages, which come in between and act as shock absorbers. So this is how this great anatomical structure of knee and vertebral column is like, and which is a main pillar for weight bearing of our body. As man has evolved from a four-legged animal to a two-one bipedal, and the evolution has definitely costed him many things. Out of that, I think the knee and vertebral column were the most to suffer because they became the main weight-bearing structures of the body. So what is this all osteoarthritis I'm talking about? Previously, it was supposed to be a very degenerative kind of wear and tear disease of the elderly, but things are changing now. A lot of research and a lot of newer information coming up about the pathogenesis of this osteoarthritis. So osteoarthritis doesn't only affect cartilage, but it also affects all the structures in and around the joint, like the synovium, the subchondral bone, the ligaments, tendons, meniscus, muscles, nerve tissues. There's basically the erosion of cartilage which is happening. With that, there is hypertrophy of the bones at the margins, which we see as osteophytes. Then there's a subchondral sclerosis. Then there's an inflammation and the degradation of proteoglycans and collagen, with release of lot of inflammatory parameters like metalloproteinases, interleukin-1 beta, TNF-alpha, nitrous oxide. And this all leads to many biomechanical changes also, leading to muscle weakness and sarcopenia. So this is how the organ fails as the wear and tear goes on and progressive. This is a normal knee X-ray, which shows some early changes with wear and tear of this cartilage, with reduction of the joint space, which further lands up into a severe deformity and the angulation or the varus deformity, what we see. And ultimately, this bilateral TKR, the patient lands up with replacement of the joints. So where is the pain exactly? We are aware that this cartilage is avascular and aneural. Then where does this pain come from? The pain is driven by joint pathophysiology and an abnormal excitability in the peripheral and central pain pathways. There are nociceptive pains which are coming from the stimulation of peripheral nerve endings, which are there in the surrounding muscles, surrounding tendons, surrounding subchondral bone. Then there is inflammation in the joint, which triggers this peripheral sensitization. And this persistent nociceptive input will result in central sensitization. So we have learned to both the speakers before about this pain transmission and pain generation. So it is aptly what is happening in the joint. But there has been a weak correlation of this pain sensitivity to actual structural damage. So more severe joint space reduction need not be a more painful joint, and vice versa. So there's a weak correlation of pain severity and radiographic features. So what does really contributes to this osteoarthritis pain is a mechanical load, then synovitis that is happening there with a low-grade inflammation. Then there's an impaired muscle function and the coordination. Deficient proprioception has been documented in these osteoarthritis joints. And there are neurobiological factors and the socio-cultural factors also which contribute to the pain. The discussion of pain cannot be concluded without we know the actual burden of this pain in the community where we live. And this has been aptly done by this COPCOR, that is a community-oriented program for control of rheumatic diseases, which was launched in 1990s by the WHO ILR. And the major mission of this particular program was to measure the burden of pain, arthritis, and disability in the community. And it has covered almost 21, 22 countries across the globe, and dominant countries being in Southeast Asia and the Middle East. And Dr. Chopra was the main coordinator of all these programs. And he has very well penned in his editorial that nobody has paid more heed to the woe of aches and pains in the community than this COPCOR program. And it is a unique fountainhead of community data on rheumatic musculoskeletal disorders and pain. Coming to this table, a huge table, but we can quickly make out the prevalences of the low back pain and knee pain, which have been really reported high in the community. And this has been in the urban setup of Asian countries as well as the rural setup of Asian countries. The risk factors may be different, but the common sites of pain are predominantly low back and neck and knee. So this has been a bone and joint decade program where we conducted surveys of population across our country and almost covered a lakh population in that. And then we come out with the statistics of our own country regarding these musculoskeletal aches and pains, as well as the prevalences of different rheumatological disorders. So this was the prevalence of osteoarthritis, where according to the region, the distribution is there. And these are again the mannequin showing the sites of maximum pain the community has encountered. The knee pain followed by this low back pain. The rural areas documenting more pain prevalences compared to urban regions. So these are some of the risk factors what I was mentioning about the osteoarthritis or about this knee pain. Maybe the setup might be a rural one where we have different lifestyles like sitting, squatting postures, then sitting on the floor continuously and doing the activities, or maybe bending and doing work in the fields, or some laborious manual activities which they perform. So all of them are definitely predisposing factors for knee and back pain. And when the scenario changes to an urban society or a community, obesity has become a dominant ever problem for this knee and back pain, apart from lack of exercise, then some traumatic injuries, then smoking, addictions, as well as continuous the IT professionals who are at risk of overstrain injuries because of long-standing bad postures. So this was a breakup of this musculoskeletal different problems in the community. And definitely it has shown that apart from inflammatory, it is major chunk of this particular rheumatic musculoskeletal burden is in the form of osteoarthritis. May it be osteoarthritis knees, hips, or spine, but this has formed a major chunk what the community is suffering from. We are again dealing with another major epidemic in our India. That is obviously a diabetes. Most dramatic increase in type 2 diabetes we have seen due to rapid urbanization and changes in the lifestyle. There's increase in diabetes in developing countries and growing incidence in the young age group. 10.5% of global adult population suffered from diabetes in 2021, and they are expected to rise over 12% by 2045. And in the aging population, what we are seeing is the coexistence of both osteoarthritis and type 2 diabetes mellitus, and this can be a greater source of disability and economic burden in aged population. So this is what we come across the meta-analysis, which is highlighting a high frequency of osteoarthritis in patients with an association between both osteoarthritis and diabetes. The risk of osteoarthritis was greater in diabetic patients, and the risk of diabetes was also found to be greater in osteoarthritis as compared to non-osteoarthritis population. Similarly, chronic back pain was also found to be more prevalent in patients with diabetes. A link between hyperglycemia and the biochemical events that occur in the intervertebral disc are also been documented. So diabetes and osteoarthritis do share some common risk factors. These are the different risk factors of osteoarthritis: the aging, the female gender. Madam already talked about this, gender differences in pain. Then there is a mechanical load, mechanical stresses. Then there is this metabolic syndrome. That is what I'll be focusing on today. It is mainly the adipose tissue, the inflammation, the mechanical stress, and the systemic lipopolysaccharides, which all lead to the damage-associated molecular patterns and ongoing low-grade inflammation in these degenerative joints. So this is what metabolic syndrome we are talking about since long. It is a co-occurrence of several known cardiovascular risk factors: the type 2 diabetes, the central obesity, the atherogenic dyslipidemia, and the hypertension. So all of these conditions are interrelated and contribute to each other and definitely elevate the overall cardiovascular risks as well as the risk of metabolic syndromes. The metabolic osteoarthritis is a new terminology now, and it affects the patients of age between 45 to 65 years. They are mainly overweight or obese, and with at least one of the components of this metabolic syndrome. That is, either they are having higher sugars, diabetes mellitus, hypertension, or dyslipidemia. The triggers for initiation or progression of this osteoarthritis is mainly the adipokines, the insulin resistance, systemic low-grade inflammation, and the lipid toxicity. This is how this pyramid shows a cumulative and negative impact of various metabolic diseases on the joint tissues, with contribution from obesity, from type 2 diabetes, mainly the insulin resistance and advanced glycation end products, then dyslipidemias, then hypertension, also leading to somewhere subchondral bone vascular ischemia, contributing to metabolic osteoarthritis. So in short, the musculoskeletal manifestations on the background of diabetes mellitus are mainly because of hyperglycemia, chronic inflammation, metabolic changes, and the glycation of collagen. So this is how this increased glucose availability or hyperglycemia and insulin resistance in diabetes will lead to formation of advanced glycation end products. And this will compound with the other metabolic factors, and they will attach to the receptors for these advanced glycation end products on the cells. And that will lead to a cascade of events leading to induction of reactive oxygen species, then increase inflammatory events, and increase in cross-linking of collagen. So this is how the picture goes. The collagen glycosylation occurs. There is abnormal cross-linking of collagen. There's increased collagen hydration. Along with that, there is also the other factors like microangiopathy of diabetes, the neuropathy, which also contribute to limited joint mobility and different musculoskeletal manifestations of diabetes. So this is how the paradigm for diabetes-induced osteoarthritis is the hyperglycemia toxicity, which can act locally, and there can be a systemic toxicity as well. The locally, the advanced glycation end products, and the oxidative stresses, which will cause abnormal subchondral bone, matrix stiffness, and they will also activate these chondrocytes and synoviocytes. And systemically, they can get activated by low-grade inflammation in the other tissues like muscles, liver, the adipose tissue, and a neuromuscular impairment. All of them will ultimately lead to this new phenotype of diabetes-induced osteoarthritis. So this is again, in short, the presentation of all those cardiometabolic factors. They are the acting cells and the final outcome in the joint, where there is a synovial, intraarticular fat inflammation, impaired bone remodeling, and suppression of cartilage anabolic activity. So coming to this obesity, which is a very common factor to diabetes and osteoarthritis. prevalent in type 2. Greater loads on weight bearing, it is not only the mechanical load, but it is a misalignment of the weight bearing joints. There's a decreased strength in muscles, which is called sarcopenic obesity, the chronic low grade inflammation in adipose tissue, and enhanced expression and secretion of pro-inflammatory cytokines, which all will lead to the inflammatory wear and tear. The obesity is associated, inflammation is always associated with severe osteoarthritis. So this pain is very peculiar. Pain is one aspect, but it produces a disability, that is a functional disability, which will affect the entire the life of an individual. So this particular disability is contributed by the pain experience, which is nociceptive input, as well as battery is running low. Central pain processing, and the disability part. So it is definitely contributed by the comorbidities, the social factors, the psychological factors, what we listen to Madam right now, then biophysical factors as well. So it is not just nociception, but the context dependent cognitive and behavioral elements are also associated with the disability part. So this is what is the impact of arthritis. What we can see here, yes, there's a physical pain, there's a discomfort, there's a lot of deformity in the knees, in the spine. Then this all will lead to definitely a dollar cost, because they will be subjected to some kind of operative procedures later or some kind of medications. And the non-visible impact of arthritis being psychological, a chronic pain syndrome, depression, then dependence because of loss of functionality, and a negative impact on relations and family as well. So disability due to musculoskeletal disorders is estimated to have increased from 1990 to 2010, in particular osteoarthritis, and is expected still to rise, continue to rise with increasing obesity, sedentary habits, and aging population. So that's where the recommendations or guidelines were mentioning and talking about the management of this knee pain or back pain. And suddenly there has been a change in this, and we can see now that even in acute as well as chronic pains, both the education, self-care, non-pharmacological therapies in form of exercise, cognitive behavioral therapies, then acupuncture, yoga, mindfulness, everything is coming up in the guidelines now, and they're finding a good place as a kind of first line treatment, especially for chronic pains, and sometimes this second line treatment as well. So that has been a definite change in the scenario. The greater emphasis on self-management, physical and psychological therapies and complementary medicine, less emphasis now on pharmacological and surgical treatments. They're encouraging addressing psychosocial factors and focus on function improvement. And they're endorsing the use of exercise, which we are again going to listen in our next talk. So definitely we are moving beyond pharmacotherapy now, which is the precise theme of this particular conference. And here, yes, we have to think about mind, as both of the speakers have really highlighted the fact about the mind. Pain is painful, and there's a relationship of body and mind, which is bidirectional. And so definitely it will be more effective to treat mind along with the body. And the low back is supposed to be a crossroads where the psyche meets the soma. And that's why people are coming up with self-help groups, self-help books, tackling about their chronic pains and sharing their experiences. So ultimately, it is a psycho, neuro, immune, endocrine kind of network. And any disturbance of any particular point definitely will lead to disturbance to other components as well. So we need to look into all of them together. So the novel therapeutic approaches for now osteoarthritis will be definitely the brain joint axis, where Madam also mentioned about that. There will be this kind of disruptions of those circadian rhythms, the HPA axis, then the dysregulation of this nervous system and the vagal anti-inflammatory arcs, desynchronization of joint tissue specific clock genes. So all of them will be involved in the pain perception. And that's why they will be important to tackle during this chronic pain. Apart from that, nowadays, one more axis is being talked a lot, that is a gut joint axis. So definitely there's a direct action of intestinal dysbiosis on osteoarthritis, involving the systemic inflammation, release of this lipopolysaccharides. Indirect effect is via the promotion of metabolic syndrome and obesity. So what all this is affecting our day-to-day practice, definitely there is an impact in our day-to-day understanding and practicing. The treating of diabetes mellitus will be definitely effective in patients of osteoarthritis. Then for patients who are diabetics and obese, definitely we would like to implement these preventive initiatives for osteoarthritis. Gut microbiome could be an interesting therapeutic target in osteoarthritis, and targeting inflammatory pathways and this mind-body concept will be very, very important later on. So what are our future targets when we are dealing with this artificial intelligence and robots which are coming up and doing surgeries? But are we moving back to our basics? Yes, definitely we are moving back to our basics, especially when we are tackling this chronic pain syndromes. So we are asking the patients now to control their weight, to watch out for their nutrition, to do the regular exercises and have a very good lifestyle. So it is a behavioral and lifestyle modification which is becoming very, very important. And that is what the madam was meaning about this biopsychosocial models. And definitely we need to stop this inflammation which can harm the body to that extent. So it is a team approach, patient-centric, obviously, with the team of family doctors, then the specialists like rheumatologists, orthopedicians, but in joint pains, now even we do need sometimes the help of the diabetologists, the psychiatrists as well, along with physiotherapists and dietitians. Definitely, this will form a good team to have a good result and have a positive health approach. So thank you for very patient listening, and we'll be happy to answer any questions. Thank you, sir.
Thank you, Dr. Vaijayanti Lagu Madam. You have elaborated in detail about the pathophysiology of the knee and the back pain, especially in diabetes, as well as the metabolic syndrome. In addition to that one, you have given the importance of the therapeutic part, more so on the PNI module and also on the gut and joint, the access between the gut and joint, that is so-called weak neuron, usually endocrinologists will tell as a incretin effect. So you elaborated, that is very important nowadays. Gut plays a major role in so many toxins, especially about the toxins. Thank you, madam. Now I request the last speaker of the today's All That Aches and Pains session is Dr. Namrata Sidde. She is physiotherapist, is a master in physiotherapy MPT. She is one of the most innovative physiotherapists in Pune, and she has done a lot of innovation, especially on the evaluation of the alligator pressure algometer and hand healer kit, which is modified for. She has become the innovator with the co-innovator in involving a new module for the benefit of the patients. I request her to present her today's role of a physiotherapist in management of the pain.
Hello, am I audible?
Yes.
Okay, thank you, Dr. Shetkar, for introducing me. I would like to thank Dr. Vaishali and her team, as well as Dr. Vaijayanti Lagu Joshi, for giving me such a great platform to talk on knee pain and back pain in diabetic patients. I will start my talk after sharing my screen. Can you all see my presentation?
Yes.
Yes.
Okay. So my topic for today is knee and back pain in diabetes, a role of physiotherapy. As Dr. Vaijayanti Lagu Joshi has given us a very detailed background about the current epidemiology of the knee and back pain. So it is a very, very prevalent joints which are getting affected as the cost of evolution. And when we are talking about knee and back pain in diabetes, it has a multifactorial etiology because as she has mentioned that it is nowadays because of our day-to-day lifestyle, it it is becoming a more of a metabolic syndrome, that is a combination of diabetes mellitus along with dyslipidemia, along with hypertension, and along with the central obesity. So all of these factors do affect our weight bearing joints, that is our mainly the lumbar spine and our knee joint, hip joint, and ankle joint. But when we are considering the weight bearing joint, the knee joint is most affected. And when we are talking about the multifactorial etiology, it is insulin resistance is a pro-inflammatory condition. So it increases the secretion of interleukin 1, tumor necrosis factor alpha in our joint, which leads to a low grade inflammation in our body, and which causes the inflammatory or the injury to our weight bearing joints, as well as the central obesity, which will lead to again release of cytokines because of the adipokines, and which is also detrimental for our weight bearing joints, as well as hypertension and our dyslipidemia will lead to peripheral resistances, which will also causes a microvasculature ischemia to the bone, and which will lead to again the degenerative conditions. So in all, the diabetes mellitus is a systemic disease which also affects our musculoskeletal system. So it is a vicious cycle. So the diabetes is there with its secondary complications, as I mentioned earlier, which will lead to the accelerated degeneration because of these complications and the insulin resistance, which will lead to pain and disability. And because of this pain and disability, acute going to chronic, will lead to inactivity, and because of that, as Dr. Geeta madam mentioned, it will lead to depression if the chronic pain is present, and because of that, non-compliance and no physical activity, which will lead to again obesity, and the cascade goes on. So our question is how to break this cycle. What is the answer to break this cycle? So the answer lies here. When the person has pain disability and the loads which are coming on the weight bearing joint, our main aim as a physical therapist is to decrease the pain, disability, take care of the disability because of it, and decrease the loads on the weight bearing joint. So the first answer is the exercise. The second answer to it, using the adjuncts like braces, orthotic prescriptions, or electrotherapeutic modalities or manual therapy. Then ergonomic advice, how to use body when you are doing your day-to-day chores, and lifestyle and behavioral modification. So if we include all of these in the management of back pain and knee pain when we are dealing with the diabetes mellitus patient, it do help us and give us the good result. So what are the types of exercises are when we are dealing with the back pain and knee pain? Is strengthening exercises including core stability, because diabetes mellitus is accompanied with many times the central obesity, so the core stability is also a main part of it. Then the flexibility and the range of motion exercises to maintain the synovial fluid nutrition to the joints, balancing and proprioceptive exercises, and aerobic exercises. So why exercises are or how exercises help in order to decrease the pain when the patient is having knee pain or back pain? It is by pain gate mechanism, because exercises give the stimulation to the large diameter fibers. By that the presynaptic inhibition happens, and by that the pain mechanism works, or the pain gate theory works. So the first in this is the strengthening and the flexibility exercise. So what is the rationale why we should give strengthening and flexibility exercises to these patients? So when we are talking about the diabetes mellitus and the obesity coming together, what happens here is there are lipid derivatives which are getting accumulated in the muscular tissue. So the muscle tissue loses its capacity to contract better, as well as there is a loss of lean body mass when we are talking about diabetes. So the strengthening is the mainstay of the exercises when we are taking care of knee and back issues in the diabetes mellitus patients. Then the flexibility. Why flexibility? Because if we see these patients, especially the back pain patients, because we have a lot of forward bending activities involved in our Indian scenario. So many of the times they have the stooped posture with the forward head, neck, rounded shoulder appearance, as well as when we are talking about knee, the varus deformity and the flexion deformity are very, very common. So we need to have a very good pliability in these structures, the anterior structures and the posterior posterior structures when we are talking about knee, so that the nutrition to the synovial fluid is maintained. So these are the some strengthening and the flexibility diagrams. Then what are the guidelines and the strengthening exercises? So if we are seeing the ULAR guidelines or the ACR guidelines, all of them, they do give importance to the strengthening exercises, and it has to be done in 8 to 12 repetitions, and according to the, it has to be a tailored made program. So according to the person's capacity, it has to go from low to moderate to vigorous intensity exercises. So what is the importance of strengthening exercises? As I said, in diabetes, there is a loss of lean body mass. So it improves the muscle mass. So when we are doing strengthening exercises, it is improving the oxidative capacity and the strength of the muscle mass. It improves the body composition because the person is getting improved with the lean body mass. It does improve the insulin sensitivity and takes care of the secondary complications. And when we are talking about the strengthening exercises, there are various types of strengthening exercises that we follow in our physiotherapeutic protocol. As we start with, if the patient is having a lot of pain, we start with the static exercises, because with the static exercises, the sense of stability is better. Then we progress to the concentric and the eccentric loading. But when we are talking about diabetes mellitus patient, as well as all other complications and knee pain and back pain, we will not give that much of strengthening the eccentric strengthening exercises to them, because they are very, very intense exercises. So it has to be a low impact activities which we will give to these patients. So the flexibility exercises is also given as a session of warm up in these patients, but it cannot replace the strengthening and aerobic part. These are the mainstay of our treatment, that is the strengthening and the aerobic part. Flexibility is one of the component that we should include either in the warm up or in the cool down exercises. Then the core stability, as we know, the why to give core stability. First, I would like to tell you the muscles which are forming the core. The first muscle that it forms is the back extensor, then the all abdominal wall muscles, then the pelvic floor muscles, and the diaphragmatic diaphragm. So all of these, they form the core. And if you see, the core muscles are divided into the global group and the local group. So the global group are the movement producers. So when we are talking about back extensors, that is the erectus spinae group, it is the global group. Or the obliques of the abdominal group is a global group, which are responsible to cause the flexion and extension of the spine, as well as quadratus lumborums and the latissimus dorsi at the side, which are responsible for the side flexion of the spine. So all these global muscles should be working better in order to give the stability to our spine. As well as there is something called as local muscles, that are your that is your transversus abdominis, which is a deep muscle of the abdominal wall, as well as the multifidus, which is also a deep muscle at the back extensor group, and the pelvic floor and the diaphragm. So all these are the local muscles which are responsible to give a proprioceptive feedback. So they maintain the relationship of one bone to other, as well as they are responsible to shear the restraint forces. So when we are talking about core stability, it is not just activating your transversus abdominis and your multifidus. It is much more than that. For local muscles to work better, you have the global muscles working in sync, then only the local muscles will be working better. So when you are talking about core stability, make sure that your hip muscles and your knee muscles, as well as your shoulder muscles, are working well, because this is, if you can see the other three diagrams, there is a lot of linkage that is there, because all the core muscles are attached to your thoracolumbar fascia. So if you can see in the first diagram that the latissimus dorsi is attached to Gmax, obliques are attached to your hip adductors, and your hip abductors and the opposite side adductors are also attached. So the hip mobility, hip strengthening, shoulder strengthening are very, very important when you're talking about core activation. So these are some of the exercises that the patient can do about core stability, which will take care of a co-contraction of the abdominal muscles as well as the back extensors. So if you can see in the previous pictures that the patient is doing activities on a stable base, and later on we can, if if you want to increase the challenge to them, then you can make them go for a unstable, make them work on unstable surfaces like a Swiss ball or a wobble board, and occluding the vision or occluding the auditory feedback also, the core stability can given, or giving the functional activities while maintaining the core engaged. So there is a systematic review which is done in 2022, that is they have seen the effectiveness of core stability exercises in patients with non-specific low back pain, and they have concluded that the core stability is important when we are talking about the taking care of the low back pain. So next exercise that we will be giving to these patients is the balancing and proprioceptive exercises. As I have mentioned that there is a loss of lean muscle mass in diabetic patients, as well as when the chronic pain is there, the muscle cannot exert its maximum effort to cause the function. So there is a loss of dynamic stability, and because it is a degenerative process, so the reactive bone formation happens, but it is haphazard. So in the soft tissue also we can see the calcification, so ligamentous structures also can be affected, which will also lead to static instability. So that is why the balancing and proprioceptive exercises are very, very important. So these proprioceptive exercises are given better in the weight bearing conditions, firstly on the stable surfaces, and to improve the challenge we can go for the unstable surfaces with the vision occluded or with vision on. Then coming to the aerobic exercises. So aerobic exercises are very, very important when we are talking about the osteoarthritis, back pain, as well as diabetes mellitus. So you can combat all three by giving aerobic exercises, because aerobic exercises improve the mitochondrial capacity. It improves the oxidative fibers in the skeletal muscle, so the muscles can work better to maintain the stability of the joints. As well as when we are doing the aerobic activity for a prolonged period of time, the fuel which is responsible for the activity is the fatty are the amino acids, which will reduce the obesity. So the first aerobic exercise that most of the people do nowadays is walking. But when we are doing walking, we are walking or jogging, which is a low impact activity. So first we should be cautious on which surface our patient is doing this activity, because a lot of studies are there which say that if the patient is doing walking or jogging on a concrete or cement road or a tar road, there is a lot of ground reaction forces that they encounter, which is detrimental for our weight bearing joint. So if they are doing that walking and jogging, it has to be on the grass surface or the soft surface, that is a muddy surface, or to be on a safer side on a treadmill. Then a lot of evidences are there which footwear to go for. So when you are doing walking or jogging, ideally when we are talking about osteoarthritis or back pain patients, we tell patients, if they are not having any other associated conditions, then we tell patients go barefoot walking, because that reduces the ground reaction force to the most. But we are talking about diabetic people, so they are prone for diabetic neuropathy. So for them, they should wear a flip flops, not stability shoes, because if we are wearing a very tight shoe or a walking shoe for that matter, it reduces the ankle mobility. So the ground reaction forces which are coming from the surface on which we are walking directly hits the knee and back. So the ankle mobility is very, very important when we are talking about knee and back. So instead of wearing the walking shoes or the running shoes, people should wear flip flops or floaters. Then the cycling is also very, very known exercise that many people do if they are having knee pain especially. And there are a lot of studies which are done for the forward, whether we should go for a forward pedaling or the backward pedaling. But if you have patellofemoral joint involvement more, then you should go for a forward pedaling, because it stresses that joint less. And if you have tibiofemoral joint involvement, then you should go for a backward pedaling. And if that is also not, if the patient cannot do walking, jogging, or cycling, there is one more method that they can opt for, is arm ergometry, which is also very, very effective method for aerobic exercises. Then if the other method which is coming up is hydrotherapy, in that with the swimming. So if we are talking about back and knee pain, people should go for backstroke or freestyle. If why not breaststroke, or why not butterfly, because a lot of shear forces and valgus forces acting on the back and knee. So if you are doing swimming, backstroke, and the freestyle, which we advise the patients to go for. So aerobic exercises are very, very talked exercises when we are talking about osteoarthritis as well as back pain. And they have given the out walking is the most prevalent exercise that the people do. And the aerobic exercises has to be 30 minutes or 60 minutes, then only our fuel will shift from the glycogen to the amino acids. And it has to be a combination which works better, that is the strengthening and aerobic exercises, because the strengthening exercises will improve the muscle mass, which can take which will improve the uptake of the glucose from the bloodstream, and aerobic exercises will improve the sensitivity of the insulin. So the combination works better for both OA as well as back pain in diabetes mellitus. So there is a lot of research whether we should do these exercises on hydrotherapy or on land. So both are very, very effective. But when we are talking about hydrotherapy, it's a time consuming process. People have to go outdoors. It is a accident prone environment. If it is elderly population that we are talking about, many of the times pools don't allow elderly to walk in the water. So that is a problems that are faced when we are talking about hydrotherapy. And there is a lot of limited evidence also when we are comparing the hydrotherapy versus land therapy. So whatever is feasible, we advise patients to go for. Now we should pay certain attention when if the patient is having a lot of acute pain, we should progress with the exercises very slowly. When we are dealing with the weight bearing joints, low impact joints, no endurance kind of running in them or the jumping activities. Yes, of course, with the exercises, the dietary advice should be done for the weight management. I am not expertise in that, but it should go hand in hand. And the people, when we start feeling better, I have seen many of the times, that is my personal experience, that people start skipping their exercises or exercise schedule. So the supervision, maintaining diaries, group exercises, or using pedometers should be incorporated in their routines for the better adherence to the exercises. Now, exercising with the diabetes is a special condition because checking, so in if the patient is having diabetes mellitus 1, so they should do the glucose level monitoring pre-exercises. Then you should not do exercises when during peak effect of insulin. Okay, so timing the workout is very, very important. If it is rapid acting insulin, it is 3 to 4 hours after the ingestion you should go for. Then timing the workout, if on inhaled insulin, 60 to 90 minutes is the ideal time to do it. There are no insulin is only a problem when we are talking about post exercise hypoglycemia. Otherwise there is no problem, or there should not be time constraint for the exercises. Additional carbohydrate supplements should be considered if on insulin. So these are certain recommendations that how to reduce the dose of insulin. Then exercising with diabetes, usually the strength training should be performed before aerobic training. So if the patient is coming to you with the OA and back pain, it should be core stability and the strengthening exercises first, and then making them walk on a treadmill. Because why this? Because with strength training, it has been seen with the evidences that there is increased release of epinephrine, non-epinephrine, which causes the chances to go hypo post exercise are very, very low. As well as there is a lactic acid accumulation with the strength training, which also causes the less chance to go hypo after exercises, as well as increased levels of catecholamines. So all these are the reasons why strength training should be performed before aerobic training. Then avoid high intensity or resistance training in diabetic retinopathy patients because of the risk of hemorrhage. You should be cautious if the patient is having more than 300 milligrams per dilution sugar levels, and avoid exercising outdoors in hot and humid climate because the diabetic people will have autonomic nervous disturbances. Now we are going to the agents that we use. So we use a lot of electrotherapy, bracing, taping, and manual therapy. Electrotherapy, all dithermy is nowadays not used at all. We use interferential currents, sometimes TENS, sometimes hydrocolloidal pack or icing, but the TENS has very low quality of evidence. Bracing, taping, they work better if we do it with the exercises and drug therapy. Then there is a lot of literature which is available, and the ULAR also give guidelines about use of cane when we are doing exercises or while we are walking, because it reduces the adduction momentum coming at the knee joint. Then there is a lot of literature on the orthotic prescriptions as well, especially given in knee pain, about medial wedges and the lateral wedges, but ULAR evidences give that we should not give wedges to these people. And the manual therapy, which works as an adjunct, we do give tibial glides, patellar mobilizations in order to really relieve pain in these patients. Then coming to the ergonomic advice and the lifestyle and behavioral modification, the first and foremost thing, limiting your daily screen time less than 60 minutes per day is very, very important nowadays, because many people have sitting jobs and they are continuously in front of television, computers. So that has to be broken down. Then avoid and limit habits like smoking, tobacco, alcohol consumption, because they have a detrimental effect on our musculoskeletal system. And the dietary restrictions and the timings for your meal should be followed when we are dealing with such patients. Now I'll be showing you some ergonomic demonstrations of lifting, standing, and when you're working on a computer, one by one. So this is how you should go when you're lifting weight. Bend from your knees, keep your spine straight, and hold the weight in front, close to your body. Next, when you are standing, take a slow stool and alternate your leg. So every half an hourly, you can keep one leg supported and other on weight bearing position. When you are working on a computer, your feet should be supported, no support for the back. You should be sitting on a throw pillow and breaking down the position by doing thoracic extension exercises every half an hourly. Then moving further ahead, what are the takeaways? That prescription of physical activity pill is very, very effective along with ergonomic guidelines and modified and lifestyle modifications. Combination of the exercise is key to have greater benefit, and tailored made exercise prescription should be followed always. Now the back exercises, we do give flexion and extension biased exercises to our patients depending on which direction they have pain. So these are some flexion biased exercises going for posterior pelvic tilt. So this is another knee to chest position, which is a flexion biased exercise. This is a progression of that. Then this is also a flexion in sitting. Then the extension biased exercises. And this is in standing. Then I have taken some videos of our own patient who is coming to us for a physiotherapy for the osteoarthritis of the knee. I'll just quickly go through the exercises that she does at our. So this is a dynamic quads with adductor activation. This is a hip flexion in non-weight bearing, strengthening. This is hamstrings. These are the side kicks, squats. This is a lunge walk. This is a hurdle walk, which our patients does in front, back side, as well as side to side. This is a TheraBand that we have used to strengthen her hip abductors better. This is what we call it as a proprioceptive exercises. So this is a grid that we call it as a star excursion balance grid. Patient has to weight bear on one leg and touch the targets with the other leg. So if you can see that she is losing balance when she is doing this. So this is also an important exercise to be given as it improves the proprioceptive feedback. This is abductor control exercise on an unstable surface. 4, 5, relax. 6, 7, 4, 5, 6, 7, 8. Relax. Now this is she's standing on a foam and trying to do reach outs. So these are some of the exercises that the patient should perform when we are giving this prescriptions to our patients with OA and back pain patients, considering all the precautions that we should take when we are talking about diabetes mellitus with all these conditions. So I conclude my presentation. Thank you.
Yeah, given such an elaborate practical demonstration of all the exercises, especially aerobic, swimming, importance of swimming, exercise, aerobic exercise, and all other exercises, and especially strengthening and flexibility, those things which hitherto most of us, and you have given very important message to us is pill. Prescription, you have to give prescription or even physical, this one also. Now, this is the last concluding part we have come of this session. I think I request all the speakers to be there. Few questions are there, at least hardly 3 or 4 questions, if not more questions. So I think we have to attend those questions. I request all of you to. Dr. Chandrasekhar sir, Dr. Geeta Desai madam, Dr. Vajanti Lagu madam, and Dr. Namrata Sidhe madam, all the 4 of you. The first question is common to all of you. Anybody, any one of you can answer. The role of acupuncture, herbal medicines, and homeopathy. Frequently, the patients come to us in the hospital telling, sir, we'll go to the physiotherapist, we'll go to acupuncturist. It is a very important Chinese medicine. It's the East, of course, it has come from the East only. In all 4 of you, anyone who can answer, all 4 can contribute. This is common problem we face day to day in our outpatient when the patient come to us for the pain.
I think I will address this question.
Okay, sir. Okay, sir. Thank you.
I face it more commonly than any one of you.
Yes.
Right. And see, I mean, I made my principles very clear in the middle of my lecture.
Yes.
The 2 fundamental principle is do no harm. That's a basic principle with which we need to work on any of the medical practice. Actually, even recently, we had a meeting across our IRA members and across my other groups of think tanks. What exactly we have to do with reference to the alternative therapies and the other medications and these things. See, I mean, there are few things we have to remember. As a patient, see, suppose I'm not a medical person and I'm an individual with some pains and aches. What I need in the end of the day is a relief in my pain. Who gives me the relief? Which system gives me the relief is a secondary part for me. So the fundamental things which we have to remember when we are advising them is number 1, is the condition on which if not the basic is not treated is going to cause an harm. Then put your foot firm and say, don't try anything. See, this is the one which I tell all my patients with systemic lupus erythematosus, vasculitis, and all these conditions, because no alternative systems can handle these group of diseases because these are very aggressive disease. A second and a minute can cause a loss of life. If it comes to osteoarthritis or if it comes to fibromyalgia, if he says that I would like to try Ayurvedic, I would like to try physical medicine, I would like to try other things, I said, with all full smile, I will say, please try and come back. If you do very well, I am very happy. I don't need to prescribe you any medications, because points are very clear. Fibromyalgia patients, a delayed treatment of years together, no big harm is going to happen. In an osteoarthritis patients, no huge harm is going to happen. So I need to be very clear when we are trying to convey it across to the patients, what is the exact point on which we are working. So beyond any doubt, I can say acupuncture do relieve the pain. The physical therapies and some of the, even the herbal drugs, especially Salaki and some of them, they have a good analgesic properties. There is no second questions on that. So the question that we need to remember is, am I only working for analgesics or a pain relief, or is there something more? I think I made those slides clear. I repeated one of the slide twice in my entire discussion, so that to make that point clear that no harm, you have every right, the patient has every right, and you have every full liberty to advise him. You can do and try whatever the best you feel is right for you.
Yeah. Totally agree. Yeah.
Next question is to rheumatologist. There are two rheumatologists and one psychiatrist. Usually come across outpatients, especially headache patients and backache patients. Despite having investigated all the needed and unneeded investigations, everything will be normal. Even especially headache patients and backache patients. So there's a big problem. Is it such patients you have to treat as a psychiatrist? You have to refer to psychiatry, and we have to see that we have to treat ourselves, or with physiotherapy or any other therapies. This is a question to the rheumatologist and psychiatrist. Both can contribute.
Okay. I'll take up.
Yes.
I'll take up the questions. Yeah. So yes, that is a very gray zone. I will say that there are few areas where there are many overlapping things and overlapping etiologies, pathologies, and there will be overlapping consultations also. That there will be definitely some contribution by other modalities or other specialities. But I think it all depends upon the approach of the clinician towards the patient, communication and conversation with the patient, what exactly the patient wants, basic possible ruling out the organic diagnosis or pathologies is very, very important before we label it as psychosomatic or something which is psychological. So that I think Geeta Madam also mentioned very well in her presentation that underlying things should be definitely diagnosed very well, and then we should put a label on that particular problem. So I think it is with discussion with the patient, then we can seek help of other modalities or other colleague consultant inputs into the management of the patient. So it should be a holistic approach, whatever ways we can help the patient and we can have an expert opinion. Definitely we should go ahead and seek the help of that particular specialty.
I'll just pitch in here because I think making a psychiatry referral is not easy for physicians because many patients have their own barriers to visit a mental health professional. But I think pain assessment is, according to me, the basic pain assessment should be done by any physician. I mean, if any basic medical degree, they should be able to assess the base pain in a proper way. Examination, there is a stepwise approach. So I think and I also feel that sometimes when we don't find the cause, just saying it as psychological can be very invalidating for the person as well. Even organic condition, the psychological factors influence the perception of pain. So I think that kind of a division is, that's where I said that pain is probably one area where mind and body, irrespective of the cause, work together. So I think making a referral is also very pertinent, and that's why I said pain communication, many a times it's one of the interesting areas that how they perceive the interaction or what the doctors told them is very, very important. It's a very interesting area we need to explore.
Yeah, just to add to that, actually, see, the patients, especially of fibromyalgia, see, the moment you say that you have fibromyalgia, not a psychiatric disorder, they're half relieved. So basically, because he thinks it's a different entity, though we have some amount of mind influencing fibromyalgia pain, but that reassurance will be a great help for him.
Okay, thank you, sir. Now, last question will be to Dr. Geeta Desai, madam. So we get plenty of patients of neuropathic pain, especially in case of diabetic or sometimes the post-injuries, especially post-neurological injuries patients, nerve injury patients. They come with a severe chronic pain. Usually we try the gabapentin, pregabalin, carbamazepine, all the things are tried. Despite that, is there any role of ketamine? But the literature tells that ketamine has to be under the hospital care and but purely under the care of the anesthetist. So what did you come across any such patients in your practice? Neuropathic pain.
I think I have not personally given ketamine, but we have tried RTMS as a method of treatment for chronic intractable neuropathic pain with some degree of benefit. But otherwise, yes, ketamine, especially if you're IV ketamine, it has to be done under supervision as much as I am aware of it. But otherwise, RTMS is something that we've used for chronic intractable neuropathy.
Because Dr. Chandrasekhar sir, such a busy man, despite that, he has spared the time and he has spent almost 2 hours with us today. And next is Dr. Geeta madam. So she is also very busy. That too, in me working in Nimans, I don't think she'll get much time to talk to us, but she has given her time to us. Thank you, madam. Next is Vajanti Lagu madam. Thanks, madam. You also taken a lot of pain and prepared so nicely. Next is Namrata Siddhe madam. She has done so good work, especially most of the things which we are aware ourselves are aware about the physiotherapy, what are the things needed and how to strengthen muscle, especially given a lot of idea to us. Thanks to all of you. And on behalf of this organization, I thank all of you. I myself thank the organization for giving this opportunity to share with you and see all of you today. I had an occasion to see you, especially Chandrasekhar sir. I am seeing him after almost long period for 15 years back. I have seen him once in Bangalore, I think, when I was in Ramaya, I think I have seen him.
Right.
After that, I was seeing once again. Thank you, sir. Thank you. Thank you, all of you. Thank you.
Thank you.
Thank you very much to the speakers, as
Thank
well
you.
as thank you, Dr. Shetkar, sir, for sparing your precious time and enlightening us with such a good summary of each of the speaker sessions after each session, and for conducting this question answer session in a wonderful manner. Thank you so very much, all the speakers.
Thank you.
Thank you. Thank you.
Good evening, everyone, and welcome to session 3 of Hall B. Today's topic for session 3 is synergy, and the moderator for this session will be Dr. Sonali Bhojne, madam. Madam is a consultant diabetologist who has done her postgraduate diploma in clinical endocrinology from the Royal College of Physicians, UK. She has a fellowship in diabetology from the Royal Liverpool Academy of UK. She is RCP certified and ACP certified, and the winner of Diabetes India Award 2021 and the director of Nectar Diabetes Center, Pune. She has recently been awarded as the Maharashtra Idol Award 2022. Over to you, madam, for this session.
Yes. Thank you, Paulami, for those kind words. And with this, we move on to our next very important session that is going to talk about the synergy or the symbiosis between the curative and the palliative care, for which we have Dr. Jayashree Shembalkar and Dr. Prafulla Shembalkar. So both of them, they are going to tell us how do we look at the problem in both the ways, like in palliative way and the curative way. I welcome Dr. Jayashree Shembalkar, who is a consultant endocrinologist. She's practicing at Gatewell Hospital since 2001. She was and also she's a director of Center for Metabolic Diseases and Osteoporosis. She was a lecturer in the Department of Endocrinology with Nair Hospitals, and also she was a fellow at London, that is Hammersmith Hospital, in 1999 and 2000. The next intro slide. And also for the same, we have Dr. Prafulla Shembalkar, who is a consultant neurologist, and he's working with Gatewell Hospital, Nagpur. DM endocrinologist, and he's presently the director of neurology department, Gatewell Hospital, Nagpur. He's done DM neurology from Grant Medical College, Mumbai. He's a lecturer at Department of Neurology, Grant Medical College and Sir JJ Group of Hospitals, Mumbai. So he was also fellow from Peripheral Neuropathy Unit, Division of Neurosciences, Imperial School of Medicine, and Hammersmith Hospital, London, England. So with this, I welcome both of you, Dr. Jayashree Shembalkar and Dr. Prafulla Shembalkar, for a very interesting talk, which is going to discuss about the curative and palliative care. Over to you, ma'am and sir.
Thank you, Dr. Sonali, for these kind words. And it's an absolute pleasure to join this session of Synergy. And I congratulate Dr. Vaishali and the entire team for the excellent effort they have put in. Every year they come out with such an innovative program, and it's an absolute pleasure to be part of it everywhere. This is a symposium named Synergy, which says that we have to act in symbiosis. So today, as clinicians, we all know that we want to have maximum therapeutic output and maximum patient satisfaction after the care. So today we are going to discuss how curative and palliative care of a disease in a symbiotic relationship will maximally give patients benefit. I would welcome Dr. Prafulla Shembalkar to start the talk. I would like to ask Dr. Prafulla why we need palliative care and what is exactly palliative care?
I would like to thank Dr. Vaishali Deshmukh for inviting me to participate in this symposium. The question why we need palliative care is really interesting question. India's population is more than 100 crore. And out of these, almost 90 lakh people die every year. Majority die in misery. Their death is agonizing and often undignified. An estimated more than 3 crore people in the country need palliative care. But how many are able to avail that? Less than 1%. So what is palliative care? It is an approach that improves the quality of life of people who are facing serious illness and their care partners.
Sorry to disturb you, sir.
Yeah.
Sir, are you from same room?
Yeah, same room. And there is a problem with my audio.
Yeah, there is echo, sir, because you are in the same room.
I think.
Or you can just log out someone and give presentation from any one ID, sir.
No, only one. Okay. Just sorry.
Palliative care is an approach that improves the quality of life of people who are facing serious illness and their care partners. It prevents and relieves suffering through the identification, assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. This slide in nutshell describes what is palliative care. Here the patient's physical, psychological, social, and spiritual needs are addressed. This improves the quality of patients and their families. It involves a multidisciplinary team. It can be given in the home care setting, or it can be given as a daycare setting. It can be even given as a OPD service. And in terminal stages, it can be utilized as hospice inpatient care. Advanced care planning is one of the important aspects of palliative care. The palliative care didn't stop with the death of the patient. It continues even after that and provides grief and bereavement support to the family. Am I audible?
Yes, sir.
Yes, sir.
Yes, sir, you are audible.
Now the voice is okay. There is no.
Yes, yes.
Much better. Yes, yes.
Yes. Thank you.
So what is actually palliative care? At the core of the palliative care is a patient and his family. It focuses on the family also. That is an important thing to remember. It is a vital and integral part of all clinical practice, whatever the illness or its stage. It can be provided alongside curative treatments. It's not a different treatment. Both the treatments can go simultaneously.
What are the principles of palliative care? Are they different from curative care?
Yes. Yeah, there is a similarity as well as there are differences. Let's first come to what are the core care principles of palliative care. The most important is that it provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. It intends neither to hasten or postpone death. It integrates the psychological and spiritual aspects of patient care. It offers a support system to patient as well as his family, and it is applicable early in the course of illness in conjunction with other therapies which are intended to prolong life. Remember, palliative care is not giving up the patient. Even in the terminal stages, we can have certain investigation whereby we can manage and understand what are the distressing clinical complications. The term psychosocial and spiritual symptoms will come again and again when we are listening to palliative care. So what are these symptoms actually? This is a very small list. Psychosocial, easy to understand, depression, anxiety, ineffective coping. That means patient has difficulty in accepting the diagnosis or the disease. Many times he is unable to communicate his distress. There is a life role transition. Suppose a patient with dementia, when the dementia is advanced, then he is no longer a caretaker of the house. Someone else has to take the care. So it is a life role transition for the patient. Many times there is a caregiver distress. Spiritual, it doesn't mean religious only. It includes many emotions like despair, hopelessness, powerlessness, loneliness, need for reconciliation. Example, one of my patients had a fight with his son and he was not talking with his son for so many years. So at the end, he realized that he has to reconcile. So that also again comes in the spiritual space.
Why palliative care is so important in neurology?
Many neurologic diseases are progressive. That means they worsen over time and often they are incurable. People living with these illnesses may experience loss of their physical as well as mental capabilities. This leads to increased dependence on others for day-to-day activities. If the patient loses his mental capability, then he is no longer able to participate in decision-making as far as the care is concerned. Here, the palliative care can be of help. It helps in assist in determining an individual's values and preferences in regards to their medical care. And it tries to align this care with these identified values and preferences. Please note that we are using the word individual rather than patient. When we say patient, we are almost dehumanizing him. Here in palliative care, we call the patient by name, or we call them as a person or as an individual. So that gives them the identity.
What are the differences between palliative and curative care?
Yeah, there is a difference in basic philosophy. Curative care is disease driven. It tries to cure the disease at any cost, and usually that is the top priority. Here the doctor is in charge. Doctor will decide the treatment and patient has to follow that treatment. Disease process here is primary. The patient usually have very few choices. Whereas palliative care is symptom driven. It is driven towards the comfort and quality of life. Person or patient is in charge. He decides what type of quality or what type of treatment he wants to have. Here the disease process is secondary to person. We don't want to cure disease, but we want to make the person happy. And usually the person will have many choices to choose. One important aspect is curative medicine strictly focuses on the goal of cure. Often this is not possible, and the patients whose disease cannot be stopped or cured are termed untreatable or beyond help. Where cure is the ultimate goal, then death is perceived as the ultimate failure. That is the symbol of medicine's inadequacy. On a basic level, thus the curative model conflicts with the notion of good death. Palliative care does not equate death with the defeat, but accepts death as a natural close of the life. In palliative care, the management plan is tailored specifically to each person's wishes according to his values and preferences. This approach contrasts with curative model, in which appropriate treatment is considered as a logical subject, and it is best decided by the physician who knows all the best. A specific treatment is appropriate only if it is beneficial from patient's perspective. It has to improve the patient's well-being. It has to make the patient comfortable. It has to make the patient symptom-free, even if the disease is not cured. Thus, the role of PC is that it doesn't replace few points about PC. It doesn't replace other forms of care. It can be integrated into existing programs. Patient can continue whatever the treatment he is taking, and it should be part of the care given to everyone with chronic or life-limiting illness.
Can you describe how palliative care enhanced care in, say, one of your patients you treated in OPD?
Yeah, everything sounds very theoretical. So let's move to the real example. Here is a patient who was a 74-year-old. He was diagnosed as atypical Parkinsonism about 7 years back. He had progressive supranuclear palsy. He was gradually worsening. He developed imbalance, falls. He was almost bedbound now. He had severe dysarthria, and it was difficult to understand whatever he is speaking. He also developed swallowing difficulty, but he refused tube feeding. Then after a few months, he was admitted in emergency with fever and altered sensorium. He was admitted in ICU. He had aspiration pneumonia. He worsened, and there was a need for mechanical ventilation. At this point, options were discussed with family. Family decided against it. Why? They wanted him to be in the hospital till daughter arrives from abroad. He was maintained, and then he was discharged to home with home nursing care. He passed away after 4 days, surrounded by wife, son, daughter, and his grandchild. After 13 days, family came and thanked the team for the support. So there are some issues we should understand from palliative care point of view. The first important principle is you have to know the person you are dealing with. That is, understand the patient as well as his family. Here, this patient was very active. He was retired from government service. After retirement, he was involved with social work. He loved traveling. he was a foodie. And it was difficult for him to accept the disability that he won't be able to go out, he won't be able to do his social work, he won't be able to go to his restaurant. On the top of it, there was no response to levodopa. So he wanted cure. He was frustrated. And now what was the family background? He stays with wife. Both the kids stays outside the city. The daughter stays in Colombia. And all the family members had unrealistic expectations. They say, we want our father to be normal, to be back to what he was doing. In spite of repeated counseling, it was a hard time for them to accept that he's not going to improve. So they went for multiple opinions, doctor shoppings. And then every time after meeting a different doctor, they will come and meet me and they will show the file that they have seen so and so. But slowly they accepted. Now with this disability, now wife is managing household. So there is a change in the role. Here he was a homemaker, he was a kingmaker, and now he is a dependent person who can't go out, who can't go to the bank, and he has to take help of his wife. So this was very destroying for him as a person. So here is the principle. We will figure this out together. Let's make plan for your care. Even though your disease is incurable, even though you are going to worsening, we are not going to abandon you. We'll try everything to make your life comfortable. Now, second issue in palliative care is what are the patient's wishes? What patients want? What medical team want may be different from what the patient wish to have. This patient has slurring of speech and then he had swallowing difficulty. He has eating was an issue. He was feeling food. His intake reduced and he lost a significant weight. At this time, PEG was suggested, but the patient refused. And I still remember his reply, I love food. I don't want to lose the taste of food. He made it clear that he did not want a life where he cannot eat, where he cannot walk unassisted, or where he cannot care for himself. Wife agreed, knowing him for whole life. But for the son and daughter, it was very difficult to accept the father now what he is. So this was, in a way, the patient was giving us his advanced care planning. He was telling what to do and what not to do when I become very sick and I cannot participate in decision making. So here the palliative care helps your doctors talk to each other. I think this slide is. You can have a say in your care. The patient can say, I don't want PEG, I don't want ventilator, everything. At the time of admission, wife was very clear. She said, you correct the correctable factors, but avoid ventilator. Our chest physician came, he suggested bronchoscopy, and he said he may need a mechanical ventilator. And he was pretty sure that this man may come out of the aspiration room. Our critical care team was also for it. But wife was very sure that this is not what he wanted. And this is the time when the palliative care can intervene. We talked with chest physician, we had a meeting with critical care and the wife, and finally all team members agreed that we should respect the patient's wishes and we should avoid bronchoscopy and mechanical ventilation. Again, wife wanted him to be alive till daughter arrives. She said, otherwise I would not have brought him to ICU. If my daughter would have been here, I would have allowed him to pass away at home. But since the daughter was about to arrive after 3 to 4 days, she wanted him to be in ICU. After daughter's arrival, then there was a very dramatic events. She started crying. She started blaming the team that you didn't care for my father. She said, now the days there is a cure for Parkinson. Why didn't you go for it? We just allowed her to vent her emotions. And then she started crying. Then we said, we understand your emotions. We can feel that what you are feeling. But after some time, and she accepted the ultimate faith that her father is really serious and nothing much can be done. So family agreed and he was discharged to home with home care assistance. He died 4 days later. So again, the message is you can have a say in your care. If we didn't know what the patient wanted, if the wife was not clear about what her husband wanted, he would have been intubated, he would have been on ventilator, and I don't know how long he would have been in the ICU. And obviously the outcome would not have been very good. So we can avoid all these things if we know what the patient wants and if the palliative care principles are applied in advance. So the salient point this patient demonstrates is that right from the diagnosis, patient many times needs support. If you say that there is no treatment, then they are devastated. There is no word like no treatment in palliative care. We always say that. We can use treatment to relieve your suffering. We can make you comfortable. Perhaps we will not be able to cure you. So it needs a lot of communication. We need to acknowledge their emotions. Why it was difficult for him to accept the diagnosis. At the same time, we should not give them false hope that sab theek ho jayega. We should not abandon them even after they went for multiple opinions. That's the reason why the family stuck with us throughout the 7 years. Symptom management was important. Advanced care discussion. This is a very important aspect, I think, in every specialty, not only neurology. No aggressive treatment in late stages. No PEG, that's what the patient wanted. And his wishes were respected. Knowing patient's wishes and organizing care according to his wishes is one of the priority service by palliative care. And we should always provide information about prognosis. This was about the medical part. But throughout these 7 years, the patient was advised about making a state will. He has not made a will. He was asked to make arrangement for the family. He was asked to make the list of tasks to be finished. And he was assured that he will not be abandoned and we will be there for him and family till the end. Dr. Jayashree, do you think this palliative care can be applied in endocrinology as well?
Yes, I think I really agree with you that palliative care is important in every field of endocrinology. But as a field, endocrinology is little different from neurology. Endocrinology is that way a very happy branch because mortality due to endocrine diseases per se is very, very rare. The commonest, but all endocrine diseases are chronic diseases, so they stay with the patient till end of life. And the commonest being diabetes and hypothyroidism. So with increasing age, as the lifespan of aging population increases, we encountered many non-communicable diseases accompanying patient in the last stages of life. And I think hence supportive or palliative care becomes more and more important to maintain the quality of life and dignity of patient till the end. I just remember a patient, 80-year-old female who was a known diabetic who was following up with me since her age of 60 years. A very compliant patient as far as diet and her drugs are concerned. And she always maintained her HbA1c around 7.5, which was acceptable for her age. But unfortunately, she developed malignancy and her intake became very unpredictable. With unpredictable intake, she continued her same medications and she suffered from repeated hypoglycemia. Even one needed admission. So both patient and caregiver were really worried about this added discomfort of hypoglycemia along with her primary malignant disease, which was really compromising her quality of life. So understanding this, I feel that in such cases, we should not aim at euglycemia and we should do everything to avoid hypoglycemia. All the diabetic patients have been told not to eat sweets during their lifetime. But in such situations, we can usually allow some sugar or sweets. Even calorie-dense food stuffs like chocolates can be allowed. If patient has vomiting, maybe keeping blood sugar little on the higher side will help in prevention of hypoglycemia. In presence of renal failure or liver, if the liver is compromised, then maybe hypoglycemia may be more severe. So taking all this into account, I think it is better to adjust the medications rather than asking them to modify their diet. And we must match our treatment or drug therapy for small frequent meals, like stopping sulfonylureas or adding repaglinide to cover their small frequent meals. If patient is on insulin, maybe we can stop premixes and start only on basal or rapid-acting insulin depending on their oral intake. As far as hypoglycemia is concerned, I have just discussed. But even we have to avoid symptomatic hyperglycemia, because hyperglycemia can really lead to metabolic decompensation like DK or HHNK. And many times steroids are used in many malignancies or end-stage lung diseases. So steroids can also exacerbate hyperglycemia. So in these patients, I feel using insulin is absolutely necessary. But we also have to keep in mind that we optimize the frequency of needle pricks for glucose monitoring. Along with diabetes, there are few other hormones, like I would say that hypothyroidism usually comes as a twin of diabetes. So hypothyroidism, if the prognosis of patient is good, then we can continue thyroxine, we should continue glucocorticoids. But at the end of the, say, life, when the prognosis is in days and hours, we can think of shifting glucocorticoids from hydrocortisone to prednisolone, which is a long-acting, or we can even think of shifting them to injectable therapies. In nutshell, I would say that endocrine perspective of palliative care would be de-prescribe medication, assess the current situation, prescribe medications as per the need for only for symptom control, and do not aim at achieving a perfect glycemic control. You can shift those patients to other routes of administrations, like from oral to subcutaneous to IV. For drugs, we can opt for short-acting drugs, or we can opt for long-acting steroids. And we should reduce unwarranted needle pricks for monitoring. We have to reassess targets on daily basis, so that we are adding quality years and dignity to the life matters rather than years to the life.
Now, just few slides about the examples of palliative care. This lady is Mrs. Barbara Bush. She was a former First Lady, wife of senior George W. Bush. She had a end-stage chronic heart failure, and she was advised hospitalization. But then she decided against it. And she gave out the press release, and I will read out that efforts to cure her disease may only prolong discomfort with little or no chance of extending the time remaining. She died 2 days later in her Houston home with her family by her side. Her decision illustrates how comfort care or palliative care can be a crucial component of dealing with a terminal illness. Now, in this picture, you are seeing two former US presidents. He is a George W. Bush, husband of Barbara Bush. He died 7 months later at home again. He had a Parkinson's disease. Ronald Reagan, we know that he had Alzheimer's disease and he was severely demented. He also died at home. And when he died, his daughter, Patty Davis, said, at the last moment, when his breathing told us this was it, he opened his eyes and looked straight at my mother. Eyes that had not opened for days did, and they were not chalky or vague. They were clear and blue and full of love. If a death can be lovely, his was. His wife, Nancy Reagan, told Ronald at that last moment that it was the greatest gift you could have given me. He died of pneumonia at his home at the age of 93. Here there are two American presidents, the most advanced medical care available, but still they chose to die at home surrounded by their families and relatives. Now coming to our beloved Atal Bihari Vajpayee, he again had advanced severe dementia. He was admitted in AIIMS. He was there for more than 2 months, 9 weeks to be exactly. He was put on life support system, including ECMO. He died at the age of 93 years. Knowing Atal Bihari Vajpayee as a person with a poetic heart, I'm not sure whether he would have asked for this type of end. Perhaps if palliative care would have been made available, or then this could have been avoided. So there are some important messages about palliative care. We will be there when you need us. Our team will support you whenever, wherever, however you need. You are not alone in this journey. Our team is always there to support you. Palliative care is an extra layer of support. At any stage of serious illness, we are here to help. Thank you for your attention.
So thank you so much, Dr. Jayashree and Dr. Praful Shembelkar for that nice presentation. Now, it is very clear that palliative care is so important, and you have given a best example by giving a clinical case and discussing a clinical case that how can we change a life, and especially I like the message from Dr. Jayashree saying that we have to extend the quality and dignity of life, not rather just the years of life. We have to add.
Dr. Sonali, you're muted.
Ma'am, you're on mute.
Thank you so much for that nice presentation, ma'am and sir. It was really nice to hear you in detail, especially with a clinical case. And you have shown us that how palliative care can be so important to our patients, especially when we are treating diabetics and Parkinson's and diabetes with cancer. I really liked ma'am's message telling that yes, we have to think about the cure of the disease, but we definitely should think about extending and adding quality and dignity to the life of our patient and not just the years to the life. I think that was the best message which both of them gave us. So I invite any questions if they are there, or rather I would start with a question because this is such a important part of our day-to-day clinical practice. And yes, we have seen how palliative care can help all our patients. So I have a question as should we start this palliative care for all the chronic diseases a little early, or should we limit this care only till the terminal stages of our life? I think both of you can take this question.
Actually, palliative care starts at the diagnosis. When you tell the patient about the diagnosis, we are breaking the news that you have got a diabetes or you have got a Parkinson disease. And many times it is shattering for them. They need time to assimilate that information. There will be a reaction from them. It could be emotional. And then we need to acknowledge that reaction and then just listen to them. So I think the palliative care starts from the diagnosis itself. As far as the prognosis is concerned, usually it is a part of communication at what time you should tell. If it is a life-threatening disease, like say dementia or something, then usually, or say motor neuron disease, where the life expectancy is in years, usually we don't disclose the prognosis in the first meeting. We slowly prepare the patient, and then after 1 or 2 visits, when the diagnosis is pretty sure, we ask them, what do you want to know about your disease? And if the patient say, I want to know everything, and then we start telling them about the prognosis. And at any point, if patient says, I don't want to listen to it further, then we stop it. So it depends on how ready the patient is to listen about the prognosis. In India, usually it is the patient who is last told. We usually tell the relatives first. We may keep the patient outside, but usually we don't follow that. We always involve patient in the discussion about the care, about the diagnosis, about the treatment plan. Yes, you do.
I feel like at the start of disease itself, if we are very clear about the nature of disease, then I think the patient is very well versed with what is the prognosis, how her life would be, and how she should cope with it. I will just give an example of patient with who comes with premature ovarian failure to us. See, this is a life-changing diagnosis for us, for her and her family as well. So it is very important to give her clear idea about how her life should be, why she should be very educated and independent and financially independent girl so that she can lead a normal life later on. Giving her options of fertility, giving her options of what is the financial cost for that fertility. I think all these things we all endocrinologists explain to the patient very well, but giving her mental support throughout her life process is extremely important. So palliative care, I feel, is just an additional cover or additional protective cloak over the curative cover, which helps to ease the pain of disease and makes the patient comfortable.
I think it's a very valid point, and I think because usually it has been thought that palliative is at the terminal stage, but then now we have really understood that for all our chronic diseases, it should start right at the beginning. Basically, for diabetes, if you say right from the acceptance of the disease, it should start. So it is a very nice to hear about all this palliative care. So now the question, ma'am, is yes, now palliative care should be a part and parcel of all the chronic diseases, right? So who should take up that role? Should the endocrinologist, should the treating physician? So who would give that palliative care?
Palliative care. Question. What is question?
Who should take up the palliative care?
I think since we have got one earphone, we will be shuffling between us. The question I believe is who should take the palliative care?
Yeah, you should be. I mean, see, it is now totally understood that it's a cover for all our chronic diseases. So whether we have to involve a specialized team or we ourselves should involve as treating physician, or whose role it is?
Yeah, the palliative care provided can be in two categories. One is the primary providers, that we are doing that. We can usually manage most of the things, but when the symptom burden is huge, like a patient with Parkinson who develop constipation, who develop nightmares, who develop falls, then you need additional help. Or if there is intractable pain, and at that point we should involve the specialist palliative care. But every clinician, I believe, is a palliative care. Usually it is given by the primary health team, that is a consultant. And at any point, if they feel that they need additional support, they should ask for a specialist palliative care. Yes, Lisa.
Thank you so much, ma'am and sir. You yourself have shown us how synergy is most important, and you have shown us practically also, like how we can really do well by acting synergistically. Yes. So thank you so much. I believe if there are no questions, we can close the session. Over to you, Pallavi.
Thank you so very much, ma'am, Dr. Bhojne ma'am, and Dr. Jayashree and Dr. Praful Shimbalkar for sparing their valuable time to come every year to educate the audience of Synapse. And this time on a very important topic like synergy. I was there throughout the session and I could tell with the clinical examples and as well as the kind of discussion that you all were putting up that it was truly a very good and a very informative session, even for a person of my education, that is an undergraduate level of an education. Thank you so very much.
Thank you. Thanks a lot.
Thank you so much, ma'am and sir. And here we close the session. Yeah.
Thank you very much. We come to the last session of this evening, that is the poster presentation as well as the oral paper presentation. For the poster presentation, we will first be showing you all the e-posters. Each will be put up on the screen for a period of 8 to 10 minutes, after which questions pertaining to the posters will be asked to the presenters. I request those who cannot access their microphones in this interim to use the chat box to ask questions, else post them to the backend team who will let the judges know. So, Mr. Vineet, Mr. Darshan, can we have the first poster, please? Dr. Kaustubh, please begin.
Am I audible?
Yes, you are audible. See, you have got 10 minutes to be precise, so we have to finish up.
Okay. Should I begin?
Yes, please.
Please do.
Hello, everyone. I am Kaustubh Joshi, currently first year MBBS student at Srimati Kashibai Navale Medical College. I'm going to talk about the patient global impressions regarding rheumatoid arthritis and bridging the doctor-patient gap, which is readily visible. So while introducing the topic, RA is a chronic inflammatory arthritis, which is predominantly seen in females, and which was also observed when we took the survey review. It not only affects the physical health, also affecting the mental as well as the social well-being of the particular patient. And basically this questionnaire was there for the patient to assess himself or herself and to know about how the patient assesses themselves. And many times the clinicians often focus on the treating aspect of the disease and not the other well-being factors which affect the patient's health. So this research topic was mainly focused on the other well-being parameters which were there. The aim was to know the patient's assessment about themselves and to collect the information about the perception of their health. What was their perspective regarding health? Firstly, a survey was handed out to the patients which were reported at the clinic or the hospital. A random cohort of 100 patients was selected, which had a common link in between them that they were RA factor positive. And the questionnaire which was used was PGIH, Patient Global Impression Health, and this was written in a vernacular language for them to understand it easily. And also no controls were involved to compare in between them. These were all RA factor positive patients which were taken. Now I come to the observations and result which were found out through the survey. And also one point which was there in material and method was that this data which was there was analyzed using an Excel sheet, and then it was represented using the graphical format. Now, what were the observations were that as RA is a predominantly female, predominantly seen in females. So the random cohort also contained 90 females and 10 males, showing the clear disparity. And the median age was 54 years, the range ranging from 17 to 78 years. The first parameter which was asked was the sleep rhythm, whether they had good sleep or disturbed sleep. So 65% patients had a good, excellent sleep, and 35% reported unsatisfactory sleep, and which was very surprising kind of a data, because we generally expect that the patients which are having these diseases, it would directly affect their sleep, but it was not the case here. In digestive cycle, the questions were regarding hunger, their appetite, and their bowel habits which were there, and 69% were satisfied with their appetite and bowel habits. Then came the energy rhythm, whether they felt energetic or lethargic, fatigued or tiredness. So 56% felt energetic and 44% reported fatigue. And the next important parameter was mental state, whether whether they assess themselves as mentally healthy or not. So 61% said that they were mentally healthy or were present in a good mental state, and the remaining 39% felt stressed about their situation. And we also asked a follow-up question about the stress, which had what was the specific reason regarding their stress. So 36% reported that they were stressed due to their disease, and the rest 64% were stressed regarding their familial reasons, job, professional lives, and some other issues. The other issues also contained some replying about financial stress and other stresses. Then came psychological engagement, where 76% were satisfied with their daily occupancy. And then were the two most important questions, regarding optimism and willpower. And also 50 more than half, that is 58%, felt optimistic and felt a ray of hope to live their lives very positively, regardless of their severity or regardless of their disease. Then came the willpower.
Dr. Kaustubh, 5 minutes are left.
Okay. Then came the willpower, and 65% had a very good willpower. And the willpower also contained one factor of addiction, and that was another question which was involved. And 65% said that they had a very good willpower. And out of them, very less percentage reported to have a weak willpower or an average willpower. And around 1% were addicted to some kind of drugs or something. Then what was then the opinion about the current treatment? So it was a very much a landslide opinion amongst the patients, because 99% of patients were satisfied about the treatment being prescribed to them. Although we also found that 86% of those patients were resorting to some other kind of measures, like there would be physiotherapy or homeopathy. Then there can be yoga, meditation. Most of them, around 66%, were resorting to measures like exercise and home remedies, and also following a particular diet. Then came the health status of the patients in the last month. So health status was 65% reported that their health status was pretty much satisfactory or good in the last month, and the remaining 35% felt that it was either average or either it was not very good, and they were not satisfied with their health in the last month. And then we also asked about their disease status in the last month, and around 21% people felt that they had no troubles whatsoever. Then 44% felt that there was no change. It was just stagnant, just as they were in the last month. They were just like now. And the rest 35% were not so satisfied, and the rest 35% felt that it was aggravated a bit. And then family relations came, and 87% felt that their family relations remained unaffected. And also we had asked about the sexual health, which is an important pillar regarding health, but many of them chose not to answer that particular question, and that is the figure 60 to 70%. So what do we conclude by this questionnaire is that by using a PGIH questionnaire, we gain a fair spectrum about what the patient assesses himself. And the PGI questionnaire, the main advantage of these questionnaires is that it is very easy to understand and record. And also we also found that despite suffering from these chronic and painful diseases, many patients were optimistic and energetic. And despite standard care of treatment, they were also resorting to many other supplementary remedies. So when we look through a clinician's perspective, we must not feel that the patient is weak. We must see it like the patient is going to be strong and resilient, and be get that by the data which was found. And there is one limitation of this survey is that it was a one-time observational assessment. When the patient came, it was a one-time survey filling thing, and it was not correlated with the disease activity. And and it is not validated. So yes, thank you.
Yes, congratulations. That was a very nice presentation. So I just have one question for you. Were all the patients whom you proposed to undergo this survey, did they all accept this, or were there any? Did everybody was ready to do this and participate in this?
Yes, they were willing to do it.
Okay. And how long did it take for one patient?
It was 5 to 10 minutes, a range of 5 to 10 minutes.
How many questions were there?
There were around 21 questions in the questionnaire, which included some objective questions, which we analyzed, and some subjective questions, which were a bit descriptive.
Okay. Did the relative was allowed to answer the questions, or it was solely with one-to-one? Like,
no, it was a one-to-one thing. It was just the patient's review. That's all.
Okay. So very good outcomes you have come with, because otherwise we think that there are mostly the negative things, and patients are with especially the chronic diseases like rheumatoid arthritis. So very good survey. Very good.
Thank you, ma'am.
Fadke sir, you want to ask something? If not,
yeah, we can proceed further.
Yeah, so we go to our next question.
It was nice to listen to the empirical data. Very interestingly, 86% people already using some or other kind of mind-body measures. So, which is like a proof, that the patient themselves give a thumbs up to mind-body medicine. They apply it by themselves. So, which is a good thing.
And it also tells us the need for it. Right. So thank you so much, Dr. Kaustubh. And now we go to the next question.
Am I audible?
Yes, you are audible. You can start.
Am I audible?
Yes, you're audible. Yes.
Yeah. So good evening, one and all. I'm from Physiology Department. I'm a faculty in Physiology Department at Amrita Institute of Medical Sciences. So in my e-poster, I would like to present the condensed form of a study, effect of integrated Amrita meditation technique on insulin resistance, insulin sensitivity, and beta cell function in type 2 diabetic subjects. Now, coming to the background of the study, we know that diabetes mellitus is a major public health concern now faced by many countries, including India. And today, diabetes is approaching the status of potential epidemic, as is projected by the statistics from the International Diabetes Federation over the years. And we know that stress is having a significant impact on the development and progression of diabetes. As we know that stress can increase the blood glucose levels, basically by inducing the release of various stress hormones like cortisol. But it can be of an adaptive significance in case of healthy individuals. But in case of diabetes, the stress-induced hyperglycemia cannot be metabolized properly. Therefore, psychosocial well-being of diabetic patients is very important clinically. Now, coming to the technique IAM, or integrated Amrita meditation, it's actually a trademark technique designed by the Mata Amritanandamayi Mutt. Is a form of meditation which encompasses yogic postures, breathing exercise, and meditation, and all the three components, which can be practiced easily within a short span of 20 minutes. It's a very simple, however, it's an effective technique encompassing all the steps of Ashtanga Yoga in a capsule format. And this practice is actually licensed and taught all over the world, free of cost, by certified practitioners. Coming to the objective of a study, the objective that of IA on insulin resistance, insulin sensitivity, and beta cell function in type 2 diabetic subjects. Then going on to the materials and the methods, in a total of there were 70 type 2 diabetic subjects. The inclusion criteria in our study was about the age group of 30 to 65 years. The duration of diabetes was around 1 to 10 years duration of diabetes. HbA1c level was about 7 to 10%. And the exclusion criteria was those practicing any other forms of physical exercise or yoga or meditation, as well as those diagnosed with advanced diabetic complications or any ongoing treatment for retinopathy, renal impairment, or uncontrolled BP. And these subjects were actually randomized into two groups, that is the IAM group or the intervention group, which received standard medical care and IAM training from the certified practitioner throughout the study period. This was a diabetic test group, and the other one was the diabetic control group, which received only the standard medical care. And the parameters or the variables which were measured was the fasting blood glucose and the fasting insulin levels was obtained in order to calculate the insulin resistance, insulin sensitivity, and beta cell function. And we used the homeostatic model assessment for calculating the HOMA-IR, HOMA-S, and HOMA-beta. These variables were measured at baseline, after 3 months, and after 6 months of study period. Coming to the results of the study, the mean age of study participants was minus 8 in case of IAM and the control group respectively. And the mean duration of the diabetes of study participants came to be about 6 plus or minus 2.75 years. And all the socio-demographic characteristics, that is the age, height, weight, body, BMI, the gender, and stress scores, they were comparable on their baseline values between the group comparison. And when the mean percentage changes from the baseline to 3 months and from baseline to 6 months were compared between the two groups, we could observe significant changes for HOMA-IR and HOMA-S from baseline to 6 months of study period, whereas the average percentage change for HOMA-beta did not show any significant changes between group comparison. Now, coming to the discussion, so regardless of the physiological outcomes, the use of the various relaxation techniques like yoga and meditation by people with diabetes can lead to improved quality of life. Meditation can, from the previous literature, it has been suggested that it can promote a feeling of well-being by lessening the activation of sympathetic system and hypothalamic adrenal axis, and thereby fostering or giving out beneficial effects on various neuroendocrine, metabolic, and systemic inflammatory responses. So it can directly enhance the parasympathetic activity, leading to positive changes in cardiovagal function, mood, and energy state. So the conclusions of the study was the regular practice of the IAM significantly reduced the insulin resistance and improved insulin sensitivity in subjects with type 2 diabetes. And these relaxation techniques can be used as an adjunctive therapy along with conventional drug therapy to help control diabetes and improve the quality of life of the subject. Thank you.
So, yes, of course, again, it reinforces and the need for other practices like yoga and mental stability and stress. So I have a question for you is like, what is this IAM? Yes. What does that contain, and is it supervised? Like, is it be taken every day, or what is the frequency? And don't you think that 3 and 6 months is a very short duration?
Yes,
to come to a conclusion like this.
Ma'am, it actually includes basically some yoga postures are there. Then we have breathing exercises and the meditation part. And the subjects were actually practicing the technique daily, and they used to come to a particular yoga hall where there was a certified practitioner who used to teach them and monitor them this technique for the study period.
And it is just for 20 minutes.
Yes, ma'am. The initial training, every day they have to practice, but for studying the technique, it takes half a day. The practitioner to give the training and for the subject subjects to learn the technique, it takes half a day. And after that, once they are trained and once they know the steps, everything, they can practice it within a span of 20 minutes, because it includes 8 minutes of yogic postures. Then there was about 2 minutes for breathing exercises and 10 minutes for the meditation.
Okay. So thank you so much. It was a nice presentation. Thank you. So we move on to our next poster. You can start.
Am I audible?
Yes, you are audible.
Yes, yes, very much. So, good evening, everyone. I'm a second year PG psychiatry student of MGM Aurangabad, Dr. Nalini Patil. I'll be presenting a case report of a patient with steroid-induced mania with psychosis. So SLE is an autoimmune, he had systemic lupus erythematosus, which is an autoimmune disease in which organs and cells undergo damage by tissue binding autoantibodies. And 90% of patients are women. The female to male ratio of SLE is 9:1. And the prevalence is grossly 15 to 50 per 1 lakh of the population. So the neuropsychiatric manifestations are reported in up to 60% of the patients with SLE. And it may have severe effects in short and long-term use. So the psychiatric effects of corticosteroids can include cognitive deficits, mood disorders, anxiety, and psychotic symptoms. And it was defined as steroid-induced psychosis initially. So the steroid-induced symptoms emerge from 3 to 4 days to a median of 11 days after the patient is started on steroid administration. And after the steroids are discontinued, the depressive symptoms may persist for 3 weeks. Mania may persist for 4 weeks, and presentation like delirium may present for about a few days. So in this case, it was a 35-year-old unmarried man who presented with initially with low intermittent fever, multiple joint pains for the past 1 month, and took symptomatic treatment, but was later referred to a specialist who on a detailed evaluation found that there were polymorphous rashes on both his upper limbs on the flexor aspects, and did further evaluation. And he was diagnosed as SLE after the anti-ANA antibodies and anti-Smith antibodies were positive. The patient was then started on 40 milligram of prednisolone and 200 milligram of hydroxychloroquine by the specialist. And he maintained well for this dose for around the first 8 days of treatment. But after which he presented to the psychiatry department with altered behavior of a 2-day duration, very short duration, and complained of inattentiveness, emotional instability, over-familiarity, over-talkativeness. Also had delusions of persecution and delusion of grandiosity on examination. And on the BPRS, we rated him using BPRS scale and YMRS scales. So on BPRS, his initial score was 66, and on YMRS, it was 32. And he was accordingly diagnosed as steroid-induced mania with psychotic symptoms, and started on risperidone tablet of 6 mg in divided doses and quetiapine 200 mg in 2 divided doses. And he initially showed improvement within the first 2 days, but on day 3, he stopped showing improvement. So we tapered the dose of prednisolone to around 20 mg per day from 40. And by the end of day 5, his BPRS score reduced to 6 and to 35, and YMRS was 12. So it was established that it was not a neuropsychiatric manifestation of SLE, but steroid-induced psychosis. So what we realized was steroid-induced mania starts from a few days to 2 weeks after administration of steroids. The risk factors can be various: female sex, past psychiatric history, prednisolone dose of usually 40 or more, and the long-term administration are major risk factors. And differentiating between neuropsychiatric SLE and steroid-induced psychosis is difficult, but clinically adequate antipsychotic treatment and tapering the dose of steroids can help us in making the diagnosis. So in conclusion, the pathophysiology of corticosteroid-induced psychosis is still poorly understood, but few studies have shown that there are hippocampal effects due to steroid use or suppression of the HPA axis by dopamine neurotransmission. And this was an interesting example of mania induced by the use of corticosteroids. Approximately 30% patients, many studies have shown that 30% of the patients receiving steroids have suffered from mania-like symptoms. The symptoms arise quickly and can be long-lasting and challenging if not treated adequately. So the patient now will require a balanced steroid use along with antipsychotic use if required in the long term. And these were the references I used for preparing this e-poster.
So, congratulations for a very distinctive case. Because usually the steroids are linked to depression, I guess, and you have shown it as a mania. So I have a question for you. You told that 90% of the patients are women. So why did you choose? Why did you go for a male patient in this presentation?
That is why I found it rare that the patient was a male patient of young, like 35-year-old male who was suffering from SLE, diagnosed just 2 months before, which in itself was a rare case. And then he, on administration of corticosteroids, he had mania, which again was rare because usually as you said, ma'am, that depressive symptoms are more common. So mania with psychosis was a rare presentation in this person. That is why I took the case.
That's a very good case. Congratulations.
Thank you, ma'am.
Thank you so much. I think we can go for the next presentation.
Am I audible?
Yes, you are audible.
Is my video visible? Because I'm not able to see my video.
Yes, it is visible. You can start.
Thank you. Good evening, everyone. I'm Akshitulsi Satyanarayana from the Department of Mind, Body Medicine and Lifestyle Science, Sri Ramachandra Institute of Higher Education and Research. My title is Family History of Type 2 Diabetes and Health Perception Among Young Adults, a Bibliometric Analysis. So we know that diabetes mellitus or type 2 diabetes is one of the majorly prevalent NCD in the world. So it is rising in number, and a number of studies have been done among the diagnosed, but not, and among the adults, but not among the young adults. So there has been a less focus on the young adults. So it's not just the young adults, but also the risk factors or the risk that they might acquire diabetes with given a family history. So there are like long-term physiological symptoms that has been long-term physiological effect of acquiring that type 2 diabetes, such as nephropathy, retinopathy, and neuropathy, among others. But what that has not been focused is the psychosocial aspect of this particular diagnosis. Each individual that gets diagnosed with type 2 diabetes, their areas of life gets affected. Let's say their quality of life, their health perception, and the way they used to live usually changes drastically. Like not over the night, but then in the period, it just gets affected. It affects their psychosocial habits as well. And there has been less studies that has focused on the psychosocial aspect on the diabetes. So the objective of the study is to identify and analyze the research focused on health perception of young adults with family history of type 2 diabetes and the hypochondriasis, which is the excessive worrying or the risk of diagnosis of the onset in oneself. So the study majorly focuses on to understand the risk factor or the worry among the young adults who might feel that they might acquire the type 2 diabetes given the family history. So the methodology used is that we identified the keywords. Using the mesh terms, we did a search in the PubMed and Scopus. So we used diabetes and family history, young adults, health perception, family risk as our key terms. So we reviewed the articles between 2013 to 2023 and analyzed, and we removed the duplicate ones and the irrelevant ones. And then we identified the bibliometric indicators and we analyzed the bibliometric data and extracted, and we used it for the study. So in the process done, there were 28 studies that were relevant in the Scopus and PubMed, and among which 7 were the most relevant ones, which were relevant to health perception and of the young adults with family history of diabetes. So among which we found that between 2013 to 2016, there were more studies done, and after that there were a little less studies, and it has picked up in the past few years. So in this decade, like in the past decade, only 28 relevant studies, and in that majorly 7 were done. And it was all done in the medical field majorly, and nursing department has done a few, and followed by psychology department. So from this bibliometric analysis, it suggests that despite several studies on health perception in diabetes, there is a research gap across global population, which this gives an understanding that we need to look into the mental health impact of the diabetes diagnosis among the family members, but not just the person who has been diagnosed. And also the scope of mind health in the prevention and management can be explored in the future studies. Thank you.
Thank you so much, and congratulations for that great analysis. So I have a question, like whether are you studying in type 2 diabetics who are already been diagnosed, or you studied the family members also?
Ma'am, this was a bibliometric analysis. So we actually screened all the available data to see what data has been, like what data is available with regard to the studies done. So we looked into type 2 diabetes diagnosis in the family. So which is the family history of people who have, like young adults who have a family history of type 2 diabetes.
Okay.
Not the individuals who are diagnosed, but then the family members are diagnosed in this case.
Okay. Okay. So what do you think? What should we do to improve upon this? Because you said there is a huge research gap across the global population for the same.
So ma'am, this topic was taken on a personal interest.
Okay.
So my parents, like my dad is, diagnosed with type 2 diabetes for the past 10, 15 years. So I have, let's say it's a health perception, or I worry a lot that I might also be susceptible to it. So I take certain measures. So, but then this is not actually addressed. Like, let's say I have that worry, but then it's not addressed, and no kind of prevention and management are available. Like, let's say, yeah, you have to exercise, you have to eat healthy, that's all there. But then majorly, like we are seeing that there are major awareness done to avoid such NCDs. But if we address particularly based on what the worry is about, we think that this can be prevented.
Yes, yes, and definitely I think that itself can reduce the prevalence of diabetes.
Yes, and stress has been identified as one of the major factors apart from sleep and eating habits and the physical inactivity. So if everything is addressed on a higher level with, the particular target, this can help there to achieve or to identify those targets.
Okay, so did you find any measure as to how to measure the stress level? Are there any scales?
Ma'am, perceived stress scale is one of the majorly used scale to assess stress levels. So this is preliminary data that we collected for the topic to explore, ma'am. So it's all in the starting phase.
Yeah, so you're going to work on it further.
Yes, ma'am.
So all the best for that, and thank you so
ma'am.
much. Thank you. Thank you.
Have a nice day.
So we go to the next one.
Mr. Darshan, do we have any more posters?
No, only 4 posters for this.
All right, all right.
So it's all done.
That's right.
All right.
All right. On behalf of the team of Synapse, I thank Dr. Bhojne ma'am and Dr. Fadke sir for their valuable time and for judging all of our posters and paper presentations and guiding them in like manner about how the concept of mind-body medicine can further be improvised upon for the coming years. Thank you very much. We will, so with this, I conclude the session for today, and we will meet again tomorrow at 9 o'clock sharp. Thank you very much.